Good afternoon, Ed.
Good afternoon, Chair.
Good afternoon, sir.
Good afternoon, Chair. Good afternoon, Councilor Flynn.
Good afternoon, gentlemen. It's good to see both of you.
Great to see you, Councilor Flynn. Thank you for having us back.
So it's always good to be with you guys.
It's good to be back.
Hi all.
Hey, Kenzie.
Hey, how are you, Ed?
Good. How you doing?
Good, good. You know, another day on Zoom.
Yep. Get ready for the snowstorm. Get those snow shovels out.
Hey, listen, I've got something better. I've got cross-country skis, so I'm hoping it's like a real, like they're promising kind of 9-inch situation. Because I can only get out in the city and use those if it's actually, you know, serious like that. But it's perfect pandemic exercise. It's outdoors, it's solo. So we'll see. Nice to see you, Mr. Chairman.
Yep.
And
get those skis to the Boston Common, Kenzie.
No, exactly. That's literally what I do.
Yeah.
It's super fun. But it only usually happens like once or twice a year. So
yeah.
So this could be it.
All right, so it's 4:05. I'm aware that we have some folks on hard time restraints, so I see the whole panel is here. I'll start now. I'm going to go into the opening and then the format, just so everybody knows, for the interest of time, because I understand that we have some time constraints for folks that are here from the administration. I'm going to go into a brief opening. I'm going to allow everybody a brief opening. Then I'm going to go beginning with the administration down. So Chief Martinez will go first. And then we'll go down the list. If folks can hold their questions until the entire panel has presented, I think that'll probably make it more time efficient. So let's go ahead and start. For the record, my name is Ricardo Arroyo, the District 5 City Councilor. I'm also the chair of the Boston City Council's Committee on Public Health. I'm joined by my colleagues, Councilor Flynn, Councilor Bach, Councilor Mejia, and I think that's it for right now. We'll be joined by others later. The public hearing is being recorded and live streamed at boston.gov City Council TV. It'll be rebroadcast at Xfinity Channel 8, RCN Channel 82, and FiOS Channel 964. We will take public testimony at the end of the hearing. If you wish to testify, please email Michelle Goldberg. It's Michelle A. Goldberg at boston.gov to sign up. When you're called, that's Gideon. He's visiting. When you are called, please state your name and affiliation, your residence, and limit your comments to no more than 2 minutes to ensure that all comments can be heard. You can also submit written testimony by emailing ccchealth@boston.gov. Today's hearing is on docket number 1125, which is an order for a hearing to discuss COVID-19 rates by neighborhoods and strategies to reduce transmission. Our expected speakers are Rita Nieves, the interim executive director at the Boston Public Health Commission, Marty Martinez, the chief of the Office of Health and Human Services, Samuel V. Scarpino, PhD, assistant professor, the Network Science Institute at Northeastern University, Manny Lopes, the CEO of East Boston Neighborhood Health Center, and Guale Valdez, the CEO of the Mattapan Neighborhood Community Health Center. And with that, I'll allow for brief openings in order of appearance. So Councilor Bach, if you have anything.
Great. Thank you, Mr. Chairman. I want to thank you for calling this hearing and everyone at BPHC for all the work you're doing. I think that we all know that with cases rising in our city and just what is it, 10 months into this, that everyone shares, I think, the stress and anxiety that the counselors and our constituents have, and we know that the health commission's taking steps every day and taking steps really in a mind towards equity and how we don't allow, well, we know that this disease is compounding the inequities of our society and of our city as they exist. And so we have to always be swimming upstream against that current. And so I'm glad this is something that I hear about from folks every day, and glad that we can have the conversation tonight, and grateful to you all for being here. So thank you, Mr. Chairman.
Thank you, Councillor Bach. We've been joined by Councillor Campbell. Councillor Flynn.
Going on here.
Thank you, Councilor Arroyo. It's good to be with you and your panelists. And I just want to highlight Chief Martinez and Rita Nieves, who've done an excellent job during the most difficult period, maybe in Boston's history. The first public meeting we ever had on COVID-19, myself and Rita and Marty Martinez organized it. We had it at the Josiah Quincy School. And we were also talking about the public health aspect, but we were also talking about a lot of civil rights issues across the country as it relates to discrimination against the Asian community. One thing that I'm proud to work with Chief Martinez on is making sure that our immigrants across our city, that they're part of this discussion, but also that we provide the services that they desperately need. So I want to say thank you to you, Councilor Arroyo, and to the panelists, and Mr. Lopes and Valdez, and I see other people here as well. I just want to highlight the tremendous work you're doing. Boston works best when we work together. We have a difficult path ahead of us over the next few months, but let's continue working together. Thank you, Councilor Arroyo.
Thank you, Councillor Flynn. Councillor Mejia, followed by Councillor Campbell.
Great, thank you. Thank you, Councilor Arroyo, for calling this hearing. As we approach the end of the council session, it's important to know that our work doesn't stop just because we stop meeting. More importantly, this virus isn't going anywhere just because our council sessions end. We need to be incredibly active and engaged in addressing the coronavirus. We knew from the beginning that this virus will disproportionately impact people of color, low-income individuals, the retail and service industry, and immigrants. That has not changed, and we're still here fighting for more to be done to protect them medically, financially, and emotionally. And I'm really looking forward to this conversation in terms of how we move forward. And I thank all of those who are here to engage in the dialogue. Thank you.
Thank you, Councillor Mejia. Councillor Campbell.
Thank you, Councilor Arroyo, for your leadership. And of course, thank you to all of the panelists for being here. And it's great to see our leaders from our community-based health centers who are doing incredible work every single day on the ground. I'm often saying, give you all the money. So thank you so much for the work you're doing. A big part of the infrastructure with respect to this pandemic. And this is such a timely conversation, right? We already knew from the beginning that this virus was going to disproportionately affect low-income residents, communities of color, and residents of color, and have a devastating impact not only on their health, but on their economics, their mental health, you name it. And we're seeing, of course, a surge come back in Boston and in the Commonwealth. Of course, communities of color have, I think, had that surge in many respects since the very beginning. But I think the conversation is quite timely to figure out what the strategies can be to respond. And couple that, of course, with the conversations around the vaccine. Many folks, of course, nervous, looking forward to continue those conversations in partnership with Councilor Arroyo and his committee. But I think there are many who think, oh, the vaccine's here, that's going to solve everything. But even with the phased approach and that the state has just released, it's going to take some time before the general public gets to see that vaccine or use it or have it apply. So much work to do. Thank you so much, Councilor Arroyo, for your leadership, and really proud to have you as a partner, particularly on the ground in Mattapan with respect to our district. So thank you. And thank you, Chief Martinez and Rita, for your leadership as well.
Thank you, Councilor Campbell. And so just briefly to center the conversation, it's an order for a hearing to discuss COVID-19 rates by neighborhoods and strategies to reduce transmissions, which is very broad. But specifically, in terms of what I would like the focus here to be today, Councilor Campbell has already filed a hearing order for the vaccine conversation, which we will have certainly, and I thank her for her leadership there. So this isn't a vaccine-centered hearing. And I think, a couple things that I expect Chief Martinez will bring folks up to date on in terms of sort of the rollbacks we've seen already and what rollbacks might be in order coming up. I think another thing that I'd like to sort of make sure we have a conversation about is we knew that a surge was coming post Thanksgiving. We know that the numbers of folks who are COVID positive are higher than they were in peaks in April and May. And so having sort of a conversation of how our hospitals and community centers are handling that, as well as what the plan for testing is. I'll give you a brief example. We've been in talks for a very long time to get a testing center in Hyde Park, which is a neighborhood that I represent. We got that thankfully online, I believe yesterday, and it's already booked. I mean, you can't find an appointment. It was already booked solid, probably within 30 minutes of it being live. And so the demand for testing is very high. And so I'd like to have those conversations. And so without any further ado on this, because I think we're heading into a Christmas surge again, I really am concerned about what those numbers will look like. I'm going to hand it over to Marty Martinez, the Chief of Health and Human Services, followed by Rita Nieves, followed by, and I don't know if you're both going to speak, so if you're not both going to speak, it's okay if one of you speaks, but I'd like you both to introduce yourselves, Manny Lopes and Guale Valdez, followed by Sam Scarpino. And I know that Chief Martinez has a time deadline, so depending on when he finishes his presentation, we may go directly into any questions for Chief Martinez so that we can release him. So thank you, everybody. And if you can go ahead and take point now, Chief Martinez.
Sure. So thank you, Councilor. Thank you, Councilor Arroyo, Councilor Bach, Councilor Campbell, Councilor Flynn, Councilor Mejia. Thank all of you for not only being here, but for giving us an opportunity a little bit to talk about what we're seeing, what we're doing, and the effort that's there. Pleased to be joined by the panel today, especially Manny and Guale, two of our community health center leaders whose teams are working day and night to respond to COVID. So thank you both for being here and all the work you continue to do. So again, I'm Marty Martinez. I'm the Chief of Health and Human Services for the City of Boston, joined with my colleague Rita Nieves, who's the Interim Executive Director of the Boston Public Health Commission. We're going to walk through some slides and attempt to be brief, but we want to walk through some information about data and strategies so that the counselor and the counselors and public can know what we're doing currently and have been doing to respond to COVID. So I think there's a slide deck here that I'd like to be able to run through. If we could bring those up, that'd be great.
Does central staff have that so they can share screen, or is it, we're just waiting to get that up?
I believe central staff has that, but.
Apologies, we had a miscommunication on our end about who was sharing. Give us one moment.
No worries.
As we start to share, I can sort of jump in if that works. So, you know, there's no question that we have, the City of Boston and our residents in particular have worked, you know, as one community to try to definitely reduce, hopefully, what's a once in a lifetime pandemic that we're experiencing. And what we want to be able to do and sort of acknowledge is all the work that's gone in by their community-based organizations, nonprofits, residents, our hospitals, our health centers, and really, for the most part, our residents themselves who have heed the warnings, wore the face covering, socially distanced themselves, and done all the things that we really are trying to get folks to do to reduce the impact of COVID in the community. But we still have seen COVID-19 have a disproportionate impact and an equitable impact in our communities of color and in key neighborhoods. And we want to walk through some of that data, which is what I'm going to do to give you a sense of what we're seeing. And then Rita's going to walk through our strategic framework of how we're responding to COVID and how we have started responding in January. It's almost been a year that we've been actively engaged and where we're continuing to go down through this work. So I'm going to show you the slides. If you go up a little bit more to the second slide, I'm not exactly sure how these slides are working here, but That second slide that's there, you'll see we have 33,000 confirmed cases here in the city of Boston as of yesterday. 25,715 folks have recovered. Unfortunately, we have 953 deaths in the city of residents in the city of Boston. And of course, our hearts go out to those families who have had to suffer sort of the ultimate impact of COVID, having had a loved one pass along. In terms of the data that you see there, in terms of our race and ethnicity, we have race and ethnicity data for about 87% of our cases. And what you see that breakout is that you see 32% of all cases in Boston are Latino and Hispanic, 30% are white, 26% Black African American, 8% is folks identifying in another category, and 5% Asian and Pacific Islander. That ethnic and racial breakdown has been consistent for quite some time, that the majority of folks with COVID in the city of Boston are people of color. In the spring, we saw Black African American rates be much higher than any other community. And then coming into the summer and fall, the Latino community surpassed the Black African American community in terms of the community that was most impacted by COVID, both by a percentage of population and overall percentage of those who had tested positive in the community. Next slide. Show you a little bit to continue this is on resident testing, and I hope these can everyone can see these, but on the resident testing piece, you'll see that what this breakdown, it's really important we create testing access. So as we're trying to create testing access, this gives you a sense of through earlier, about 2 weeks ago, of the total number of people who've been tested by race and ethnicity. And so although the largest bucket of continuous testing is in the white community, singular, in communities of color, Latino, African American, Asian, and other, who are folks who do not identify in these racial buckets, that continues to be that we're testing more folks that are not in the white community than are in the white community. We have a large bucket of missing or unknown category as when this data comes in, and that data, when it gets categorized based on case investigations or additional information, at a very high number falls into a community of color category. So we continue to see the percentage of testing that's happening and continue to monitor to ensure that we're creating access across our neighborhoods and across our populations. Next slide. So when we think about looking at the data, one thing that's been central to our response from the Boston Public Health Commission and Health and Human Services and the administration is to look at the equity lens and to make sure we're understanding how this has impacted our Black and Brown communities. And so in terms of cases and deaths by race and ethnicity as of December 9th, you see the breakdown. The orange is the percentage of cases that are within the population. The blue is the percentage of deaths that are of that community and that population. And then the gray is the percentage of the population in the city of Boston. So you'll see the Latinx Hispanic community has had the highest percentage of cases in the city, very much so compared to its population, and the Black African American community has had the largest percentage of deaths at 34% compared to its population. The white community has had 45% of all deaths, as well, in the community being at the highest percentage, but is on par with its population percentage for the city. And so we continue to monitor this. Again, the big shift that we've seen in this data, although it's been pretty consistent, is that the Black African American percentage of cases had been very high in the 40% of cases earlier in the spring. That came down as more people were tested and more people had access, but the Latinx and Latino population went up in terms of the percentage of cases. On the cumulative Boston COVID-19 cases by age, we continue to see the largest group, 7,300 cases have been in the age of 20 to 29 years of age. And we've seen that increase quite a bit over the fall. A couple of things I want to share with you on this data set is you'll see that older age had been less cases in the 60 to 69 and up. But that's where the severity of cases have tended to fall. Those being that COVID has disproportionately impacted older Bostonians as well. Just to give you some sense of this, this is over the course of COVID, but in the last 2 weeks alone, 65% of all of our cases in the city have been under the age of 39. And so that continues a trend we've seen through the fall and into the winter now, where 65% of those cases are under 39. And that is a higher percentage than had been earlier in the spring. In addition, when we look at the percentage of cases in the last 2 weeks, in terms of race and ethnicity, we see that 28% have been Latinx, 21% have been Black, and 37% of those cases have been white in the last 2 weeks. So the reason I share that with you is that not only do we look at this data across the entire span of COVID, but we're also looking at this data within a small time frame, 2-4 weeks, so we can sort of see what we're seeing in our neighborhoods as well, so we can understand the impact. Next slide. So the increased COVID activity has spread. We see this. Our current daily 7-day average is 438 cases as of December 6th. This average has been a steady increase over the last several months, and is higher than it even had been in April, when we had a peak of about 330 cases for several days. This increase has been sort of gone up into this area after Thanksgiving. Our current positive test rate is 7.2% as of December 6th. And that rate gives you a sense of kind of context that in June, we were hovering around 2-3% at times. So we've continued to see that rate increase. It's well below our peak, but again, we're kind of comparing different things. Our peak, people were mostly just getting tested if they were symptomatic. That's where most of the access was available. So we have a 7.2% positivity, and we've seen this go up and down, but it has climbed since Thanksgiving. Lots of more people getting tested, but a lot more positive cases. Next slide. So you'll see this again, went over this data, 438 cases per day is the average right now, 7.2 is the current positivity. All of this data is available on the Boston Public Health Commission website and is posted, updated Wednesday morning and Saturday morning every week. Next slide. So this is the neighborhood-based data, and I know that this is obviously important data, and I wanted to just spend a minute or so here, conscious of time. So what we're looking at again is we look at our neighborhoods to understand what is the current positivity, what was it the week before, the 7 days before, when we look at these rolling averages, what does it look like the current number of tests that week, the prior week, and then what is our testing rate per 100,000 residents, both the testing rate and our positive rate. And unfortunately, over the past couple of weeks, we've continued to see an increase in our positive rate. You'll see here that every neighborhood, with the exception of the 2 zip codes in Fenway, did see an increase in our positive test rate. We also did see, for the most part, almost every neighborhood see an increase in the number of people getting tested and the number of tests performed from the prior week to the current week. And that's also an important indicator, is we really want to make sure people are getting access to testing, but we also see the current positive rate and continue to see the neighborhoods that are most impacted. Dorchester, all 4 zip codes, East Boston, and Hyde Park have continuously been neighborhoods that have been over the citywide average, which is why we have tried to increase testing access, why we've tried to increase community mobilization efforts, and why we've tried to make sure to partner with our community health centers to increase access across the board. Although other neighborhoods like Roxbury, Roslindale, and Mattapan have had higher than citywide rates, it has gone above and under the citywide average. So what we've tried to do is really focus on those neighborhoods that have the higher positivity rates and lower testing rates, so that we can continue to respond and increase access to resources across the board, and do our very best to make sure that those opportunities are there. But this data shows you that there's those increases in rates in these neighborhoods, which just about 6 weeks ago were not in the same area. Next slide. So in the last Two pieces I'm going to cover before I pass it to Rita has to do with increased COVID spread. So when we see the increased rates, what we need to do is understand what we're seeing in our hospitals. And that's the big difference between where we were in the spring in terms of numbers and where we are today. Although we've seen increased activity in the Boston emergency departments, and although we've seen increased activity in hospitalizations and in our ICU, we're not at the same level of severity in our hospitals that we were in the spring. We currently have about 320 COVID positive patients in our Boston hospitals. In the peak in the spring, we were about 1,600 patients in our Boston hospitals. So we're not at the same level of severity. The climb also was very quick in the spring, and we've seen a slow increase here. So our hospitals have been clear that they feel prepared to take care of those most severely impacted, but there's no question that we're seeing more activity. We're seeing hospitals be challenged by increased hospital admissions, staffing challenges with people working in hospitals testing positive, and generally trying to make sure they can take care of folks. But we are in constant conversation and contact with the hospitals, which Rita will mention, but that is an increase that we continue to see. And last but not least, I want to mention that the other activity piece continues is that rates in communities of color have been disproportionate. And as I think it was Councilor Mejia may have mentioned, this has been the case throughout COVID, that Black and brown Bostonians have been disproportionately impacted, and that has continued. The shifts in the numbers may have occurred since the beginning, but that has been a disproportionate impact, which is why we've continued to work with our community-based organizations to be able to do community mobilization, testing access, and partner with our health centers who predominantly serve our communities of color across the city of Boston. So I want to briefly pass this to Rita Nieves. Rita is going to walk through, I covered these metrics. So we're going to go to I'll show you the next slide, this slide. Rita is going to cover what the response has looked like. And I know we have a lot of slides here, so I think Rita is going to give a quick overview so we can make time for questions or pass to the other participants. But Rita is going to cover some of the strategies that we are engaged in and focused on as we respond to COVID. Rita?
Thank you, Chief Martinez. Thank you, Councilor Arroyo, Bach, Mejia, Flynn, and Campbell for the opportunity to have a conversation with you about, what we've been doing and what are our plans for the upcoming months, regarding our response to the pandemic. So this slide that you have in front of you is just, an image that we put together to show how, there are so many components to the response that we've been having to the pandemic since February. And I'm just going to highlight how we have enhanced our response, and the strategies will be implemented in the next 60 days. So, as you can imagine, access to testing has been a key strategy that we've had to implement, and we've been at this for many, many, many months. Informing, ourselves, our partners and our residents and city government around data, and improving our ability to collect and capture the data that's needed for us to make informed decisions and to keep everybody informed on how the pandemic is evolving. It's, obviously has also been a key aspect of our work. Contact tracing, following up on cases, also key to also mitigating the transmission of the virus. Enforcement and restrictions. I'll talk a little bit about the restrictions at the end. Ensuring that there's isolation capacity, especially for vulnerable populations and places where we send people who needed to be quarantined or isolated. And working with our healthcare infrastructure, not only our hospitals, but our health centers and other providers. And lastly, doing community outreach and resident outreach to ensure that we stay connected with folks, brought information, and also are able to bring back information as to what were the concerns, issues around access to testing services, and anything people were saying out in the community that they needed and were not getting. All of this, obviously, always making sure that all of our decisions and planning we're guided by equity, prioritizing our most vulnerable populations who were in need of support and services. Next slide, please. So, we have established, and it's quite, have been documented that COVID-19 has had an inequitable impact on specific populations. Chief Martinez covered the data around people of color, and, Latinx community continues to see higher rates of infection than any other group. Our latest numbers show 32% of our cases are in the Latinx community. And while the size of the Latinx population in Boston is 19%, and Black African American residents have had the highest rate of infection at the beginning, and have maintained the highest rate of mortality throughout the pandemic. You all know that our older Bostonians, were heavily impacted by the pandemic, and we continue to work very closely with the long-term care facilities, checking with them every week and really monitoring any rise on cases, and supporting them with PPE, with training, with consultation, and anything they need, just to make sure that we don't experience the same issues we experienced back in the spring. And our unsheltered Bostonians, who, as you know, are very vulnerable and have no place to isolate or quarantine. It's a group that we have done an enormous amount of work with our partners to establish surveillance testing, to de-densify the shelters so we didn't have so much crowding, and mitigate any transmission. So we're very happy with what's happening in our shelters and our ability to really keep things under control. Over the months of the summer, we went for about 8 weeks without a single case in our shelters. So that speaks to all the different strategies that we implemented, and also with our partners, Healthcare for the Homeless and other shelters. Next, please. So in terms of our testing capacity, our testing capacity, has evolved over time. I was fortunate to be one of the persons from the commission that had to work very closely with the health centers since the month of March. So we were able to assist, all health centers in the city to ramp up testing. We were able to facilitate that. They got resiliency funds dollars. So every single health center got that first award so they could ramp up testing. And, all of them were able to do a tremendous amount of work at the beginning of the pandemic. Then in the summer months, we went back to them, and now using CARES Act dollars that we had, we were able to fund a number of them to not only ramp up their testing, but also go outside their facility and be able to do community testing in community sites, such as churches and other types of facilities. They were able to also support our work going to BHA housing and really going into facilities that we had high density of folks and low numbers of testing. So, the role that the health centers have played, it's been, incredibly significant and important in helping us really get, increased access to testing in many, many aspects of our society. We also then work at coming up with mobile testing units, and East Boston Health Center, right now, Harbor Street, Whittier Street. We have another vendor that it's doing mobile testing unit for us in Jamaica Plain. And using the mobile testing unit model, we've been able to move around the city and following the data, and going to those neighborhoods that were spiking and showing, very high positivity rates, we were able to quickly go into those neighborhoods with the mobile testing units and be able to increase access very quickly. So we are doing that right now. We'll continue to do that and continue to find opportunities, look for opportunities to increase our ability to move services like that through mobile units. And lastly, we also with the health centers, we have contracted with a number of them to help us support testing for BPS students and staff. Once, hopefully in not so far future, when we begin to roll out reopening of in-person for regular, students, we'll be able to count on some of the health centers that will fast track either staff or students who may need additional support around testing, or for any special situations where we have a cluster, for example, and the health centers. There are a number of health centers that are already lined up to play that role. Next. We also have been, for a while, we had a lot of testing capacity in many of our neighborhoods. And it coincided with, the weather still being warm and people, having other interests, enjoying the outdoors and not worrying so much about COVID. So we got to a point where we had, more capacity than the demand. And so one of the things that we have done over the last, I would say 6-7 weeks, is to really increase the number of unique individuals that are coming in to be tested. And we've done that by promoting, access and need for testing. One of the things that the mayor did, it's roll out the Get the Test Boston campaign and encourage employers to take the pledge to help employees get free time so they could come and get access, get tested, and we're helping with that. We did that with city government employees as well, and that has really contributed to the fact that we have a little bit more than 50% of the residents of Boston have been tested at least once. So we're very happy with how things are going with our ability to get people tested when they want, and and we've also worked to ensure that our frontline and essential workers continue to have access to testing. We're doing that with first responders and our employees who work in recovery and our shelters, and also we've continued to do surveillance testing in our shelters to again make sure that we monitor how the virus is spreading and catch any spikes. Next, please.
Rita, sorry, Councilor Arroyo, I just wanted to step in. So we have 6 or 7 more slides. There's a bunch around response that we wanted to be able to share with the council. So I wanted to check in with you, Councilor, to see how, if you wanted Rita to finish and continue. There's a lot more richness, but I just am conscious of the time. So you're perfect.
I think just being conscious for time, it makes more sense for us to go into the Q&A. And then if a part of the Q&A can be answered using the slides, then we can pull it back up, or you can cite right off of the slide. But I think it makes more, because we all have it. All the counselors have the slides. I actually read all through them while you were presenting. So I'm all the way through the slides. So I think just to note, by the way, that we've been joined by Councilor Braden and Councilor O'Malley. I think it makes sense to go in order of arrival. And Councilor Asabi George as well. Sorry about that. They've been here, by the way, for the majority of the presentation. I just didn't want to interrupt. And so I think it makes sense to go in order of arrival with questions specifically for Chief Martinez, because I know he has, I believe it was sent to us that you had about a 5 o'clock hard stop. Probably not going to be exactly out of here at 5, but we're going to try and get you out of here as close to that.
Both Rita and I have a vaccine conversation that's really critical that starts at 5. So
we definitely want to go through this. So I'm going to ask folks to ask their questions have them prepared in advance. And so Councilor Bach, followed by Councilor Flynn, followed by Councilor Mejia.
Great, thanks so much. Mine, pointing to one of the slides you didn't get to, is around isolation housing. I wonder if you guys could speak about, I'm definitely continuing to be concerned about the unsheltered population. Just, you know, I think we've done an enormous amount as a city on that front, but there's still a lot to do. And then when I saw, you know, it was interesting and alarming seeing your numbers, both about the Hispanic and African-American community. And with the Hispanic numbers, you know, obviously the number of deaths was under proportion, but number of cases was over. And it just made me think about how many of our, you know, younger folks in the Hispanic community are essential workers and frontline folks, and also how likely that community is to be doubled up and housed really, really densely. And so I think the opportunities for isolation housing there, you know, it's something that we've talked about, frankly, since the spring. And I saw on your slide a reference to sort of a Chelsea Everett option. I haven't heard a lot about what the opportunities are for someone who lives in really dense housing and finds out that they're COVID positive and is worried about maybe infecting a vulnerable loved one. And I was wondering if you could speak specifically to that issue, because it's something that I've been hoping we would devote more resources to in general.
Yeah, so thanks, Councilor Rock. So as you referenced, as you know, we lifted up a variety of locations in the spring for our unhoused population to have access, I think 4 different locations to both de-densify our shelters and create isolation and quarantine space for folks within the homeless community. And so that was central to really controlling the spread of COVID in the community, in the homeless population. And I think that's been important. And so a lot of work went into that effort to make that happen. Currently, we've continue to partner with Healthcare for the Homeless to do ongoing surveillance testing in our shelters, not just the city-run shelters, but the private nonprofit shelters. And that's also really important because the rate's very low in our shelters. It's less than 2% positive cases. And so what that's allowed us to do is we've de-densified enough so that if there is a case, we're able to isolate that individual. They're able to go either to Barbara McGinnis House, or we also have access to 2 hotels in partnership with the state where we can send somebody if they need to isolate. That is also accessible to folks who are not just unsheltered, but there's also the ability for folks to be able to use that if they test positive through either a health center or a hospital to be able to utilize that resource. I will suggest that it's not about the availability of the resource, but about the usage. I think that there's no question, and I think East Boston Neighborhood Health Center found this out, so did the state, that although some of those sources are available, it's much more difficult to ask somebody to leave their family and their home to go isolate at a hotel for 14 days when many people have other responsibilities and other things that they just cannot go do that from. So although the city of Chelsea, other cities had isolation hotels specifically targeting the immigrant community, they had very low usage. And when we did even focus groups with residents who tested positive about use of isolation spaces, they were clear that leaving their family was not really going to be an option that they could do. So they needed more education about how to keep themselves safe, keep their family safe in their household, in addition to trying to figure out how to help others along the way. So we do have isolation space today. Health centers have the ability to refer, and we've done that in partnership with the state. In our homeless population, we have enough beds for folks to be able to both isolate and quarantine if needed. But in order to prevent that from happening, we've really increased the surveillance testing for our unsheltered population so we could avoid any kind of outbreak like we saw in the spring. So that's really central to that work around isolation.
Thank you.
Sorry, can I ask a quick follow-up, Councilor Arroyo?
Yes.
Just since we're here, like, you know, and folks may be watching at home, if one of us as a counselor knows somebody who would like isolation housing, or somebody knows somebody's in a tough living situation, like what's the actual way for someone to pursue and raise their hand and say, hey, I would really love to take advantage of that?
Yeah, so if someone wants to do that, these referrals have to be referred by a clinical partner because the person has to we need to be able to verify that the person's tested positive. So if you call the mayor's health line, we can provide the information. If we call the mayor's health line, then they would be notified that the person would be notified that they need to get a clinical partner to make that referral. We have to be able to verify that someone's COVID positive to be able to take advantage of those. But if you call the mayor's health line, Counselor, we'd be glad to connect with that person directly.
Okay, and so for somebody, but their doctor, their community health center, those are people who could. And then if they don't have one of those, call the helpline and we can.
Yeah, absolutely. They'll have to have some verification that they're COVID positive, which is why it has to be a clinical referral.
And then my one other question, I mean, I have a million, but I know there's a long line of colleagues, so I'll ask it and then Councilor Arroyo can cut it off and have you answer it on the next round. But just, you know, on the contact tracing front, I think we all hear a lot, especially whenever orders come out like this week around closures and things that are still open, about kind of the ability or inability to ID where spread is happening and the types of contacts. And obviously we've got a lot of disbelief right now that I'm more likely to get COVID if I'm masked in a gym than if I'm unmasked in a restaurant, right? And so, and that's something I'm fielding lots of questions about from constituents. And so I just wonder if you could speak to, it seemed to me the last time we talked about this, like our contact tracing was running to catch up with who might not yet know they were infected. And so our ability to look back and figure out where things happened was more limited. But I also see you all talking a lot about informal gatherings, which suggests me that there's at least some data telling you where people are maybe getting sick. So that's a question we're all getting. So I would love to hear you answer it, whether in response to me or after other colleagues.
Councilor Arroyo, do you want me to answer that or?
Yeah, if you can, if it's brief, if you can
Okay.
do like a brief answer to that.
So very briefly, I think you're right, Councilor Bach, that right now, for the most part, although the state's lifted up more contact tracing capacity, as has Bphc, the contact tracing is trying to chasing that. So I think the thing to keep in mind around where people are getting it, again, you're absolutely correct. It's very difficult to say a person got it here. What's not difficult is to be able to see where a person may have infected others in terms of who was a close contact. And that obviously there's some science around it. I think the thing to remember about the restrictions that are put into place, at least what we did in the city of Boston, we went back to the state guidelines, which was the earlier phase, right? So the last phase that we just put into place, phase 2, section 2 of that, it had a set of things that it closed and some things that were open per the state guidelines. So we followed that with the notion being very clear between myself and Rita Neves and Dr. Lowe, our medical director. We want to take the number of people that are actively engaged in non-essential activities. We're trying to take them out of the universe in some way, right? If you have a universe of people, then the less we can have people engaging with other people in spaces, we would like to be able to do that. So it doesn't mean that a specific industry is causing the spread of COVID in particular. What it does mean is that we want less people to be engaging in things that they don't need to engage in right now within the context of what the state guidelines were that exist. So that's the balance that we're trying to make, I would argue, in terms of what restrictions are in place and what's closing. It has more to do with the guidelines as well as how can we encourage more people to stay home and less people to engage in things that they don't need to do at this moment.
Can I add something to that, Councilor?
Yes.
So really the principles that we look at is, what type of activities, people are engaging in that involves people from mixing households, people from mixing households coming together, and, movie theaters and gyms and places like that fit that criteria. And also, what are activities that are put you at higher risk? And when you think about going into a restaurant, you're sitting with other 5 people, you're taking your mask off for an hour and a half, and you're eating and you're laughing, and lots of air droplets are being shared in that space. So that's why restaurants, and bar seating, for example, fit that criteria too, because, they are places where people from different households are coming together and really not having an opportunity to wear a mask 100% of the time. So the risk for transmission is way higher in those activities.
Thank you both. And so my hope is, just so everybody knows, there will be no second round with the administration. So my hope is that we ask questions in this first round that other people have. I'm already scratching off questions that Kenzie had so that we can sort of maximize the time here. So Councillor Flynn, Councillor Mejia, followed by Councillor Campbell. And this just for folks on the back end of that, so they know Councillor Braden, Councillor O'Malley, Councillor Nisa Sabi-George, and we've been joined by President Janey. And then I'll finish in back cleanup, and then we'll send you off on your way. Thank you. So Councillor Flynn.
Thank you, Councilor Arroyo. To Chief or to Rita, you know, I know we did a lot of work in reaching out to residents in BHA during this pandemic, testing and in public health education. But Chief or Rita, I guess my question is, as it relates to the vaccination, what will the message be to hard to reach residents, whether it's in BHA, whether it's immigrants, whether it's seniors, in working with Language Access, Office of Immigrant Advancement, BHA, the public schools? What are you thinking about in terms of a public awareness education campaign for hard to reach residents?
So I'll be brief because I know, as Councilor Arroyo mentioned, I think we're going to have another hearing about the vaccine. So we have a comprehensive communication plan that we're developing and working through in partnership with health centers and hospitals to really reach those folks in communities of color, in hard to reach populations, to encourage them to not only get the information that they need to make the best decision for themselves and their families, but to encourage getting vaccinated. So we have a whole campaign we're working through. We'd be glad to share more with you all, but you're absolutely right, Councilor Flynn. There's many, many Bostonians who do not plan to get the vaccine. And if they do, they want to wait a year. And we unfortunately need a very high rate much sooner than a year from now to sort of get the benefits. So we're working through that and glad to share more with you as we have the next hearing.
And part of the planning process is involving focus groups with community-based organizations and residents. So we don't assume what the issues are and the challenges and the questions people have, but really inform, you know, that campaign with what people are saying and what people are asking about the campaign.
Thank you, Rita. Thank you, Chief. I have no further questions. Thank you, Councilor Arroyo.
Thank you, Councillor Flynn. Councillor Mejia.
Yeah, so thank you, Councillor Arroyo. Just so that I'm clear, this is it? No more questions after this? Are we done?
Yeah, so there will be more questions, just that'll go to the community health centers and Sam Scarpino, the epidemiologist. But if you have a question for the administration, it's in this round.
Okay, great. So thank you for that clarity. I am curious in regards to what Commissioner Nieves just mentioned in terms of the restaurants and the droplets and an hour and a half sitting in one place. How is that different than students sitting in Boston Public Schools in regards to exposure? What's the science behind those two things?
Well, in school, the students, I'll just answer the question about the mask. You know, students and staff and any adults in the schools are supposed to be wearing a mask, you know, the whole time that they're indoors and outdoors as well. So that's a huge difference. And then social distancing is required too. So in restaurants, you know, you're sitting next to each other, you know, like you're if you're eating with 5 other people in a table of 6, there's no social distancing happening there. So the proximity of people, it's way more than anything that's happening in school.
Okay, thank you. And then one more question, just because I want to be super mindful that my colleagues also. I'm just curious, you know, there are a lot of folks when it comes to neighborhoods with large numbers of college students who are attending in-person classes. COVID positive rates are impacted not just to the students and faculty, but the surrounding community. And what is the reasoning to keep these schools open? And is the city advising any changes to the higher education institutions?
Yeah, so that's a great question, Councilor Mejia. We, as you know, the purview of colleges and universities lives with the state. The state has the ability to allow them to be operating. However, we have requested from them before they open, we requested infection control plans from the colleges and universities to help us know how many students they were bringing, how they were testing them, how they were isolating them, and how they were making sure to not only test students and staff, but also other essential staff that are serving those students. We have had another meeting with the colleges and universities just this week, where we asked them if they plan to try to do anything in addition to what they were already doing, that they need to provide us additional information on those infection control plans. We're using sort of every leverage we have to make sure that they're keeping not only the students safe and the staff, but also the surrounding neighborhoods. So we don't have the ability to say you can't come back. They fall under the state purview, but what we do have the ability to do is get that information for them, push them to test even more. I will say the positive rate's been very low in the testing that they've done, but it's a good point that we need to continue to make sure we're monitoring and staying on top of any activity that they're responsible for.
Yeah, and I want to be super mindful that I have other colleagues waiting, so I'll spare you the rest of my questions, and thank you so much for all your hard work. It's greatly appreciated.
Thank you, Councilor Mahan. One thing for colleagues who do still have questions and would have needed a second or third round, if you send those questions to me, I will send those questions to the administration so that they can respond to those questions in writing, and then I'll distribute it. Councilor Campbell, followed by Councilor O'Malley, followed by Councilor Anissa Sabi-George, followed by President Janey. So Councilor Campbell.
I'll defer because I would like to hear from the community-based organizations too. I know we have the presentation and appreciate Chief Martinez and Reader's work, so I will give my time to the other panelists.
Thank you so much. Councilor O'Malley, followed by Councilor Anissa Sabi-George, followed by President Janey.
I'm going to cut in because I don't see Councilor O'Malley anymore on the screen.
Now.
Thank you, Mr. Chair, and thank you to the administration and Chief and Director Nieves for joining us. And I did tune in a few minutes late, so I do, coming in from another commitment, I do hope that you can share that presentation with us. Did you go over at all any of the testing that's happening in our communities specific to our schools that have been reopening? If you did, I'm happy to just review the presentation.
We did not. It's not included in that data. We can share if we can share that information in terms of what's happening. I will tell you this week we are starting a BPS pilot this week. A pilot that will be testing at 15 different schools. We'll be testing all 9th through 12th graders at that school and all staff at that school. And then we also offered teachers and staff at other schools that were opening, the other 18, they were all invited to be tested either today at one of 4 sites or they were offered to attend our community site in Jamaica Plain. So we are trying to make testing accessible through that pilot, but we can share the current numbers of infections overall and can share that with the council afterwards.
Great. And then my other question is, and this may be more appropriate for Chief Barros at some point, but received a few calls today around some of the gyms that were shut down or that will be shut down starting tomorrow. And just curious if there is an opportunity similar to the bars who are able to present sort of a change in plans around safer seating at the bar, if there is an opportunity for gyms who have had either no positives within their membership or can create sort of some special designs that make it a safer environment for them to continue operating. Will there be sort of more appeals opportunities within different industries, but the gyms in particular I heard from today?
Yeah, so what I can tell you is right now that those restrictions are across the board for the next 3 weeks, and we're not, with that exception of restaurants being able to file an additional piece of information, there's no other way to get an exemption on that front. I mean, what we're really trying to do again is make some tough choices here about what we have open and what we don't, in an effort also as we bring back students to try to balance that out. So that won't be available for those gyms.
Yeah, no, I appreciate that. And, you know, it obviously is a difficult time for everybody, but I had that question specifically to me today, so I wanted to ask it here. Thank you, everyone, for being here, and look forward to the next panel as well.
Thank you so much. President Janey.
Thank you so much, Mr. Chair, and many thanks to everyone on the panel. I'm hopeful that we are taking lessons from the surge earlier in the spring and applying them, and interested in hearing what they are. I did join late, so I don't want to take everyone's time here, perhaps asking questions that have been already asked, but I'm deeply concerned just that the numbers, when we're looking at the Black community, the Latinx community in particular, that we continue to see the disproportionate impact in terms of cases, and then how are we taking that information really to inform our thinking, not only for, test access, which I think we're doing, good at now. Certainly that's been my personal experience, as well as the experience I'm hearing from constituents. So again, grateful for that. But how will we use this to inform our thinking in terms of vaccine? And I know we're a ways off in terms of how the general public will get access to it, but I think now is the time to plan, and that it's important to use the information that we have before us to inform that thinking. And if you've discussed that already, again, happy to view the tape and move on to the next panel. That will be it for me, because again, I know we're mindful of time and we've got a big meeting tomorrow, as well as this important hearing. Thank you again, Mr. Chair, and thank you to this panel.
Thank you, President.
So I guess the only thing I would say to that, Councilor Janey, President Janey, is that you're absolutely right. I mean, we've seen the disproportionate impact and the inequity that's existed. And so all along the way, the commission and HHS and administration, we're looking at what have we learned, what are we seeing, and how do we update, how do we respond, and how do we evolve our strategies and our efforts. So specifically how it connects to prevention and the vaccine, just briefly, is that what we learned is we had to do a better job of making sure that people understood the prevention messages, who was delivering those prevention messages in neighborhoods and in communities, how we were ensuring that community-based organizations, faith-based organizations that were on the ground in a way that they could spread the message in neighborhoods, that was critically important to getting more people to access testing, more people to isolate, and more people to figure out how to keep their family safe if they tested positive. So we learned some of that messaging through the spring. We've learned some of that messaging into the summer and have used that as we sort of seen this uptick in the surge, especially as we message around holiday gatherings and gatherings as it gets colder in people's homes. So we're going to directly tie that to the vaccine work, but there's no question we have to not only see what we're seeing and understand the data and dissect it, but we also have to respond to it on the ground and shift strategies, which we've had to do along the way.
I agree. And I would say that there's an added challenge, particularly in communities of color, specifically the Black community, when it comes to vaccines, in terms of overcoming the mistrust that is out there. When it comes to government institutions, medical institutions, et cetera, based on the history. So I'm interested in continuing this conversation, and I believe we can do that not only with the next panel, but with the next hearing when we do get to talk about the vaccine more specifically. Thank you again for the opportunity, Mr. Chair.
Can I add something, Councilor?
Yes.
So, President Janey, so great, that's a really great question. So, a couple of things I wanted to add is that we learn to also expand our capacity to do community-based work, and we are adding some ambassadors, which are meant to be like community outreach workers. And we have a collaboration with the Mass Immigrants and Refugee Association, who are helping us identify folks who are immigrants, who were healthcare workers in their countries, who are multilingual, that will be able to be hired by the commission and will be able to be teamed up with staff of the commission and be sent out there with messaging, not only about prevention, but also about the vaccine. And obviously we'll place them in communities of color. And lastly, we have a very strong history of collaborating with community health centers and the healthcare system. And we're already hearing from focus groups that folks will be looking out for whatever their primary care provider will say to them about the vaccine, and that they will trust their PCP about that. So I think what we have to do is really make sure that we connect and partner with the health centers, especially, and other PCPs very early on how to combine forces and really integrate our messaging, so we can really get good information out there and start building trust and really teaming up with the people who are going to be asked by folks, should I take this or not? So that's something we have to do slightly different in this phase of the pandemic.
Thank you. And so I'm going to ask my questions now. I've condensed them largely, so they're really in 3 buckets. And so I'm probably going to ask one for each bucket. Specifically, when we talk about neighborhood testing, I know one of the things that I've gotten back a lot is that these sort of hit and run, you have like a week or 2 weeks here, you have the mobile testing spots have been confusing for residents because they're not permanent. There's no ability to make a, oh, I can go back to that place now again. What are we doing to ensure that there's permanent testing in each neighborhood? In Hyde Park specifically, this has been an issue. What are we doing to ensure permanent testing sites, especially in the winter, for every neighborhood in the city? What are we doing to do that?
So I appreciate the question, Councilor Arroyo. I mean, I think the focus for us on testing has been to build on the current infrastructure, and you're going to hear from 2 folks who've been testing since the beginning, as early on as they could, from Manny and Guale. You're going to hear the current infrastructure has been our focus. How do we build on community health centers' capacity to test? Then we set up 3 mobile testing operations to be able to not only create some access in some neighborhoods, but also to be able to create access, even if there is a community health center in a neighborhood, sometimes it's not accessible to everyone in that neighborhood. And so to create another access point in those places. And we've prioritized places where there's been low testing access and a higher positivity rate. And so we've tried to make sure that we can do that. The point that you raised about the mobile testing, that's an excellent point. We do not have either the infrastructure or the financial resources to put multiple testing sites in one neighborhood. We don't have the ability to do that. And so what we've tried to do is to be able to bring testing to neighborhoods and to bring testing locations in that mobile capacity. So many of our health centers, including East Boston and Mattapan, have been able to not only test locally, but many of our health centers have also allowed us to be able to test at BHA buildings, at senior buildings, have allowed us to be able to test at visiting nurses association buildings that are not falling into the state, into our homeless population. So we've tried to be able to piece together the testing apparatus to do that, and also to be able to make sure that we can have access across the board as we can, and make things accessible that we might normally not have done, like the CVS testing that's happening across the city that we normally would not have promoted or advocated with, but that was another resource that was necessary. So we're working right now. The Hyde Park site that you referenced will be there at least for the next 6 to 8 weeks, is the goal for that site. We are working to expand. We have a site in JP right now. We have our mobile site that's moving between Roxbury and Dorchester. And then we have our health centers that are actively testing at our BHA buildings right now. So we're trying to bring as much capacity on as we can, and continuing to do that with limited resources currently, and even less when the year ends, because the federal government has not provided additional federal money to support testing locally.
Thank you. And it's important to note that federal lapse. And so one other piece related to this in terms of equity, I've heard from multiple people about issues with transportation to testing centers. They don't have their own vehicles. Is the city doing anything, especially in the winter months? Folks should not be walking miles to a testing center in snow or ice or any of these kind of conditions. Are we doing anything to provide transportation, or alternatively, are we doing anything to do either our own partnerships as a city to reimburse those costs, or private-public partnerships with companies to reimburse costs of transportation for COVID testing?
So that's a great question. We have not explored a testing partnership. I don't know if either of the health center EDs that are on are doing any of that locally. It's something we can look into, but we've not explored transportation tied to testing. We have not done that. One of the reasons to keep in mind is that it's very difficult, and we don't want to promote people riding together in vehicles or people going together in groups. So the transportation thing is a challenge, but it's something we can definitely look into. I haven't heard much of this complaint, but I appreciate it, and we can look into it.
I have received several constituent calls about this where they've been told they have to provide their own transportation, but they don't have vehicles, and the nearest testing center is like 4 or 5 miles away.
Yeah.
So it is something that has come up, including during this hearing. I've gotten an email about it. And so another issue In terms of the colleges, they obviously have their own testing systems set up and their own sort of streamlined process for results. What are they doing, or what are we doing to have them sort of share that with the community, share that with Bostonians?
Great question, Counselor. We have worked with them to ensure that they are not just testing students and professors, but that they were also testing essential workers that we know are on their campuses and many times living in their neighborhoods. So we've partnered with them to do that. We've also encouraged them to test more of their students, right? Because not all students on campus are being tested the entire time. There are many students who are living off campus or who are remote. So we've also encouraged them to expand what that definition is who's getting tested. And then we partnered with health centers to help us, or not health centers, I'm sorry, with the colleges and universities to explore lab usage. Some of them have additional space in their labs to be able to partner with the health center to test more. And to be able to do that, as you know, one of our challenges has been lab turnaround time for results. And so we've looked at that as well. So the colleges and universities, I'm going to just be clear, before they were coming in, I think doomsday was what you read on every website and Twitter and on the paper. We haven't seen that in the colleges and universities in their work. So I'm grateful for what they've done, but they've stayed sort of in their bucket, and we want to continue to work with them to see how they can support us, especially as we think about the next step around prevention, but also the vaccine.
Thank you on that. And then this is for Director Nieves. What metrics does BPHC, the Boston Public Health Commission, use when they're making decisions regarding BPS school reopening?
Actually, we use all of the metrics we use to make decisions about policy or any decisions we need to make about the city. Because, when we think about saying it's okay to open a school or schools, we need to look at the context, and the context is the city. So we look at what is it that our metrics are telling us as to how fast in the magnitude of the spread of the virus in the community. And then the other metrics that tells us what is our healthcare system capacity to treat people who are getting sick. So it's a combination of all those metrics that we look at to then come up with a recommendation or saying, given the context, it's okay, and given the whatever strategies and measures and safety measures that BPS have put into place in those schools, given all those things, is that we then make recommendations based on that.
So I just want to kind of condense that without putting words in your mouth. It sounds like you're using the infection rate.
We use a positivity rate, number of cases, how many people are being tested, how many people are showing up in emergency departments with COVID-like symptoms, how many ICU beds are being utilized, and how many beds the hospitals that are non-surge beds are being used, because it tells us, are the hospitals getting overwhelmed? And if they are, that spells trouble for everybody. So
within that, I have a second question to the second part of that, which is, you said sort of the conditions or the precautions put in place by BPS. Every school building in BPS is a little bit different from another, right? The reality is we have some school buildings that likely have as modern as you can get in terms of their HVAC and everything else that's going on. We have other schools that haven't been updated since they were built in like the 60s, right? So the question I have for the BPHC is, when you're making a question on opening, what I've had an issue with is it's sort of a blanket open or close. You yes or no. It's similar to our budget, right? But my concern with that is not every school in BPS has the same functionality as another school. And so whereas you might make a decision that this school has proper procedures, proper HVAC, proper everything, that's fine. This other school, though, doesn't have that. But on the whole, we're going to say open. Are you making decisions on a school by school basis or on the system as a whole?
So, BPS, whenever we've been consulted about a decision about reopening, whether it's 4 schools or 28 more, they're required to develop plans that are specific to the school. And, you're right, each school is different, and especially around facility stuff are different. But what we pay attention to is, there's some basic measures that have to be put into place around safety and around environmental, items, and around prevention, right? And so we set the bar. Everybody has to be able to say, we're going to be able to do this in this school. And they have to be consistent with DESE and CDC guidelines. So when we look at, every plan for each school, if they meet the criteria, then we're saying, okay, they're meeting the minimum standards to operate safely. We also look at, how many students are they bringing in and how many adults. And, we always, go back to them and say, you must have just the amount of adults in the building that are required to be able to teach those 10, 20 students, 30 students, no more. Because obviously, we want to ensure that we don't have an unnecessary amount of folks in the building just because the building is open,
Thank you. And so in looking at the time, I'm going to end it there. We'll send you the questions that we have. I want to thank you both for taking the time to be here and for your candor and answering questions. I'll make sure that I collect the questions remaining from my council colleagues so that we can send to you moving forward. And so thank you so much. If you have any closing things that you'd like to say before we hand off to the next panel, please do feel free.
The only last thing I'd say is thank you, Councilor Arroyo, and thank you to the counselors for your effort. And I appreciate anything you can continue to do to lift up the messaging that we're experiencing around the holidays. People staying home, people celebrating with their own household. We saw a spike after Thanksgiving, that was clear, and we will see another one after Christmas and after the holidays if we don't continue that message of spending it with our own households. So again, thank you for helping to lift up that message. Appreciate it.
Thank you so much.
Thank you for all the counselors and for you to putting this together. And big thanks to Manny Lopes and Wale Valdez. They've been incredible partners in the work we've been doing for months. And without the health centers, we would have been in big trouble. So they have stepped up to the plate in many, many, many ways. So we really appreciate their partnership and their support and all the contributions they made to the city. So thank you.
Thank you. And so with that, you're both free to go to your next meeting. Thank you. I'm going to go to Mr. Lopes, Mr. Valdez, and Mr. Scarpino in that order.
Okay. Thank you, Chair Arroyo, and thank you to all the counselors for inviting us to share with you our experience during this really difficult time for our health center as well as our city. I have prepared remarks, but I think for the purpose of time, I'll just go very quickly. Many of you are very familiar with East Boston Neighborhood Health Center. We are a large community health center servicing the neighborhood of East Boston, as well now as the South End with the acquisition of South End Community Health Center. As you're also aware, 80% of our patients live below the live at or below the 200% of the federal poverty level. And many of our patients are the essential workers that you hear about, working in jobs that do not translate into remote or working from home settings, which means they are at higher risk of contracting the virus, whether it's during their commutes as part of their workday, or even coming home, as we've already heard, and living in multi-generational households. For the health center, we have, I think, responded well to the pandemic in our community. We've provided cultural appropriate outreach materials. We've stood up testing sites. In fact, we stood up the first testing site in the state, the drive-through testing site for first responders at Suffolk Downs in partnership with the Boston Public Health Commission and the city. And we've adjusted our operations based on the positivity levels in our community. With the current surge, we have moved, reopened up our incident command. And we have moved to a status of orange. So that's one step before we get to red. And that means transition routine care to telehealth, in-person routine care to telehealth. So we are in the process of transitioning 70% of our in-person care to telehealth care, so we can continue to deliver services to our community. And we've suspended many of our high-risk activities, and we've implemented screening protocols at our front door. To stop the spread and to prevent exposure and to identify infections, we've also taken a number of steps in terms of, again, providing cultural appropriate materials, engaging with some of our trusted community-based organizations to help us disseminate information, and to also help us understand how to best respond to the community. To identify infection, of course, we've stood up testing sites, including Chairman Arroyo, the High Park site that you referenced that just recently opened up. We are responsible for that site as well. And just your question around it filling to capacity very quickly, we intentionally limited capacity in its first couple of days, just so we could test out the workflows and make sure that we had all the right resources we need, knowing that that site will get very busy very quickly. The capacity that is set, hopefully in the next couple of days, will be at 500 tests per day. And that's significantly higher than many of the testing sites across the state. And we have the capacity to move that to 1,000 per day, which we've done before at any single site. So we do have quite a bit of experience in that area. I'll pause there for any questions or turn it over to my esteemed colleague, Gwale from Mattapan Health Center.
Mr. Valdez, you can go ahead.
Okay. Chairman Arroyo, members of the council, thank you for the opportunity to share our story and our approach in Mattapan. When I think about a strategy or I think about addressing a problem, what I do is I break it up into components. I break it up into sections and then address each section. And I came up with 4: testing, tracing, care, and messaging as our strategy. And I thought the best way to share with you what we're doing is to give you a real example. I couldn't have asked for a more current example than something that happened this morning. So our testing has to be flexible, and it has been flexible. Given the mobile testing that's been done, we have actually rented a trailer so we can test in the winter. We've used grant funding that we've received to hire tents to free up our staff to provide ongoing care. Our thanks to Whittier Street, our thanks to Rosendale, our thanks to Harvard Street, our thanks to East Boston, who have come into Mattapan to help us do testing. And this is where these partnerships come in, and this is where we become adaptive. But one of the best things that's just recently happened is Binax Now. So it's a rapid test. It is to be used for individuals who are showing symptoms. The first test was done at 10 o'clock this morning. We received 400 test kits on Friday. The first 2 tests were done at 10 o'clock this morning. Both of those tests came back positive. Now, our approach is we do the test, we ask you to go home, and we'll call you within about 30 minutes to an hour. So we developed new workflows within about 2 days. So the first test, husband and wife, came back positive. And this is where we reached out, gave the message, and now we get into tracing, contact tracing. The purpose for the call is to tell you your results. So you're going to take the call, and there's already, the word trust was used earlier on the trust that we have with our patients, the trust that we develop when we do this testing. So you've answered the call, this is where we give you your results. And we do a modified form, or what I'm calling a modified form of contact tracing. Now, we were involved in contact tracing very early on. We had to pull our staff off to redeploy them to other activities within the health center. What we found out is individuals are less likely to answer the phone because it's going to come up unknown. And individuals are very unlikely to give you their contacts. It's personal, and they're going to hold on to it. So what we decided to do was, while we're delivering the news, the message, provide support to let you know what to expect, to let you know that we are available if you have questions, to let you know when the appropriate time to go to the emergency room is. But what we also do is we use this opportunity to promote how much you care about the people in your family and the people and your friends. What we ask you to do is, now that you've tested positive, and we regret that you tested positive, please contact your friends. Please contact your family, anybody that you've been in touch with for the last 3 to 5 days. Let them know you tested positive. Encourage them to get tested. The best contact tracer is someone that you know, and someone that you trust, and someone that when they call you, you're going to answer the phone. This is not indicative, and it's still extremely early to develop, to come up with any kind of conclusion on this. Of the first 12 rapid tests that we did, and keep in mind, we know that the positivity rate is going to be high because we're using it for individuals with distinct symptoms. Of the first 12 tests that we did this morning, 6 came back positive. Now, the implications of this from a strategic standpoint are, there are now 6 individuals who didn't have to wait 4 to 5 days to get their test result. And we're taking full advantage of that. So now there's 6 individuals, and this is where the care component comes in. We're asking you, and this is where also the practicality comes in. How are you going to eat? How are you going to make sure you have what you need? So what we're doing is we're encouraging you to reach out to friends, And then we give them advice on when they deliver, ask them to deliver food for you. Leave that on your doorstep. Don't engage. Don't have an encounter with another individual. And if you're having difficulties, call us back. We'll put you in touch with help. That's where the care component comes in. And also the messaging. The messaging is what's consistent, what has to be consistent through each of these 3 areas. Please get tested. Once you're tested, if you're positive, please quarantine. Let us know what we can do to help. And then we'll help you make arrangements regarding care. 2 of the individuals that were tested are from Mattapan. They came back positive. 2 of the individuals were from Dorchester, was from Brockton, and another individual was from Hyde Park. And once again, this is part of our strategy. Get tested, but the results have to be timely. This is the fastest we've ever been able to give a result within 15 to 30 minutes. These calls were made at 10:30. The first 2 tests were done at 10. The calls were made at 10:30. And we're hoping that this is a significant part of our strategy, that the information needs to be. So I'll keep my comments brief and turn it over to see if anyone has any questions.
Thank you, Mr. Valdez. And so we'll go to questions in a second. I want to give Mr. Scarpino a chance to give his opening, and then we'll have a question for both you, Mr. Lopes, and Mr. Scarpino.
Thank you.
Great. Thank you very much, Councilor Arroyo, and the rest of the councilors, Chief Martinez and Director Nieves, who left. Thank you so much, and to other co-panelists. I appreciate you taking the time to be here and update us. I prepared a few slides, but I think in the interest of time, I'll just describe what's in the slides, but I am happy to share them if it would be helpful. So we're looking primarily at data at the state level in Boston. The state level in Massachusetts. These are data that are typically publicly available either through U.S. Health and Human Services or through the state. We're also, of course, looking at city data from Boston, also from the greater Boston area and surrounding communities. And the trends that I want to point out that I think are most concerning kind of mirror what we've heard already this evening. The first is the increasing rates and increasing numbers of hospitalizations. So we can see that they have gone up dramatically over the past month. But if you look at the data, we can clearly identify a trend of hospitals doubling month on month since about September. So we've really been on this growth trajectory pretty consistently in terms of hospitalizations, in terms of test positivity rates, really since September. And there was an unusual period during Thanksgiving because the testing patterns were different than we'd seen before. And that disrupted some of our understanding about what was happening. And so we're only now really starting to get far enough away from Thanksgiving to get a better sense for whether any of the measures that went in over the past month or so are actually having much of a measurable effect. So that's the first thing that I want to mention, is that the hospital numbers are climbing. Our forecast suggests that sometime in the next 2 weeks, it's going to be between 2,000 and 3,500 hospitalizations statewide. Now, that uncertainty comes from what happened over Thanksgiving. So we've had a slightly higher hospitalization rate over the past few weeks than we had in September and October. But as we've seen recently, that hospitalization rate has come back down a bit. And so there's a lot of uncertainty, and we're going to have to watch very, very carefully over the next week or so to find out whether we're on that trajectory towards the low end, which is still really very, very serious, or towards the high end. And importantly, that high end of 3,500 hospitalizations puts us back pre-phase one in terms of the total number of hospitalized patients on any given day for COVID in the state. The second thing that I want to point out is that the testing data is very, very hard to interpret because the majority of the tests, depending on the day, somewhere between 2/3 and 75% of the tests are run at colleges and universities and other locations that are repeatedly testing the members of their community. So there's, I think, somewhere around 20,000 tests a day, maybe, that are getting run on first-time test takers. Of course, that varies a lot day to day, depending on whether we're on the weekend or not. And so because so many of these populations that are repeatedly testing their populations have very, very low test positivity rates, so under 1% on the universities, probably around 1 to 2% in some of the other locations, that brings that statewide average number down. And as we heard on during the hearing this evening, and we've seen regularly, COVID is a local disease. COVID is hitting different communities disproportionately throughout Boston, throughout Massachusetts, throughout the United States, and globally. As you continue to zoom out from the neighborhoods in Boston, the same kind of pattern appears, and it's affecting individuals similarly in terms of issues associated with racism and xenophobia, depending on where you are in the country or where you are nationally. But so because this is really a local problem, not in the sense that it's up to the local individuals to solve it, but that looking at the test positivity data, we really need to have very local, granular information on what's happening in each of our communities with the test positivity rates, because they're varying so dramatically, which is something that we see in the Boston Public Health Commission data. They do one of the better jobs of reporting those sorts of granular pieces. So the second piece is that the testing data are very, very hard to interpret. A high volume is testing locations like the colleges and universities. The third piece is that the mobility patterns we see around the state of Massachusetts and in Boston are different than they've ever been in years and in pre-pandemic. So during the lockdowns in the spring, all forms of mobility dropped to 30%, 25% of normal. So commute flows, the number of social contacts you have, the amount of time you spend with those social contacts, how far you go outside of your house to go for groceries, all of those dropped precipitously. But they've rebounded differentially over the past few months. And the one metric that has continued to creep up month on month, tracking the hospitalizations, is commute flow into the greater Boston area. So the number of social contacts, the amount of time people spend with social contacts, the distance people are traveling outside of their household, not for work, those have all rebounded, but have been fairly steady for the past few months. But it's that commute flow back into Boston that has been going up over the past couple of months. And we, importantly, because these are anonymized data, we don't know whether these are people going to restaurants, bars, other entertainment, or whether they're going for work. We think it's a mix of both of those, but importantly, it's that movement in and out of Boston that keeps going up and is tracking those increasing hospitalizations, tracking those increasing those test positivities. So the third piece is that the mobility data really are pointing towards this role of commuter flow, because it's one of the only things that's been changing regularly over the past few weeks and months. And then the last thing, and I'm happy to share this slide, and I would be very curious to hear from the Boston Public Health Commission if they have data on this. We're seeing in the national, and so the Health and Human Services through Freedom of Information Act request had to release facility level data on inpatient hospitalizations nationally for COVID-19. So we have an unprecedented look now at what's Boston down to age groups. So we can bin individuals into different age groups and look at hospitalizations. The rate of hospitalizations for individuals under Yep.
I don't want to cut you off there because I know you're in a flow, but you said a slide. Do you want to screen share just so we can see what you're seeing?
I can show just very quickly here. Yeah.
Perfect.
So can you see my screen?
Yep. Perfect.
So these are the adult hospitalizations for the state of Massachusetts 7-day average, going from October through about 2 weeks ago, which is the last round of data from HHS. You see this steady increase that we've seen. These are the concurrent number of daily hospitalizations. We're at about 1,500 now. The forecast is somewhere between 2,000 and 3,500. These are under 18 currently hospitalized, which had been fairly flat through the past few months, had dipped into November and then have shot up pretty dramatically in the past few weeks. And as I mentioned, we don't have the last 2 weeks of data, so we don't know if this was some kind of blip because of Thanksgiving or whether this is the trajectory that we're on. But given that we heard from the Boston Public Health Commission that a majority of individuals are under 39 who are testing positive, I think we need to be a very close look at data from groups that we haven't previously been watching, namely individuals that are in younger age groups, to be tracking these hospitalizations. So my hope is that this is a blip, but I think this is something that has just come to our attention. Well, this is something I know that has just come to our attention, but I think it's something that all of us need to be paying very, very close attention to and circling up on. So I'm going to stop screen sharing there, and I'll just reiterate the messages that I'd like to bring across. Is the first that, and actually I'll have a 0th message, which is the disproportionate effects of COVID-19 globally, nationally, statewide, citywide. That means that we have to have equity as a key feature of things like vaccination. I know that's a part of the upcoming conversation, but the epidemiological data, overwhelming evidence that equity needs to be a part of the vaccine delivery decisions because of how unequal the burdens have been all over Boston, all over Massachusetts, the US, and nationally. Then the first thing would be hospitalizations are way up. They have slowed a little bit. We need to be tracking them very, very carefully because there's quite a bit of uncertainty in whether we're heading towards basically a red line or something that is very, very serious, but could be manageable and something we can bring back under control. So we got to be watching very closely over the next couple of weeks, especially as we move into the winter holidays. Third thing, the mobility patterns, most of them have been fairly stable aside from commute flow. So I think the kinds of things we're seeing in the greater Boston area, Somerville, are the right kinds of steps, and we're going to have to see whether that brings things back into the right kinds of direction. Although, as came up before, without additional federal support, it's a very, very difficult situation. And then the last is we are seeing a very worrying trend in the HHS data around under 18 hospitalizations. And I would encourage this group to look very, very carefully at that to ascertain whether this is just a blip and something that hopefully is just going to pass through relatively quickly, or if this is actually a trend that we're on and something that we're going to need to really take quick action around. So thank you very much for having me. And again, happy to take questions with the other panelists.
Thank you, Mr. Scarpino, as well as Mr. Lopes and Mr. Valdez. I'm going to open it up to questions, but before I do that, I saw Councilor Sabi George had a question regarding, I believe, Mr. Scarpino's presentation, and I want to let her ask it.
Yeah, thank you very much, Mr. Chairman. I don't know whether my internet went out for a second, but what was the information that you FOIA'd from HHS?
So HHS, I'm happy to share this. They had to make all of the facility level data for COVID-19 publicly available as a part of Freedom of Information Act request. They legally should have been doing this from the beginning of COVID, but that's all public now. And so
what's facility level mean?
So hospital level, the individual hospitals.
So at the hospital, and then what type of care within the hospital? Like what level of care?
That's a good question. I think it's ICU and inpatient, but I'll have to go back and check. Yeah, it's a lot of data to sift through.
I was just unsure what that meant. Thank you.
And if you can send that to my office, Mr. Scarpino, I'll make sure everybody on the council gets it. Actually, I think you should send it to Michelle Goldberg, which is Michelle A. Goldberg at boston.gov, and then she'll redistribute it to the rest of the council.
Great, I will do that.
That would be very helpful. Thank you so much. And with that, I'm going to go to questions directly. We can start with Councilor Flynn. We've had a few folks who've had to jump off for other meetings. And so the actual list is much shorter now. It's Councillor Flynn, followed by Councillor Mejia, followed by Councillor Anissa Sabi-George, followed by Councillor City Council President Janey, followed by myself. So starting with Councillor Flynn.
Thank you. Thank you, Councilor Arroyo. My question is to the three panelists. During this pandemic, during the testing, the pandemic, and we go into the vaccination, but over the last year, what other public health challenges have we seen, such as substance use, that may have contributed, the COVID may have contributed to some of these related public health emergencies or challenges that we're now facing and that we're going to have to continue facing after the pandemic and after the vaccination phase as well? Any comments about what else you're seeing out there that we need to address immediately?
I guess, yeah, good. Mr. Valdez.
We definitely don't have the presence that we did before. And the reason for that is this type of treatment, this type of counseling lends itself to doing it in person. And we now have restrictions on the number of individuals that are coming into our building. And we have such strong patient demand for just general primary care services, behavioral health services, dental services. We're trying to do this via telehealth. It's not lending itself to a telehealth environment. So we're seeing a decrease in our own activity, and we know that this is making the problem worse. But we're, like I said, we're doing the best we can, and we have individuals who are trying to get in, but then it's also really difficult to get in touch with them and get them to come in. And we're looking at cutting face-to-face visits even further, which means the problem is just it's going to get worse.
Thank you, sir. Appreciate your comments. I have one follow-up question. Wasn't sure if the other panelists wanted to weigh in, but then
just briefly add that I think it's across the board. I mean, everything we've looked at is that basically everybody's pushing everything off, and whether that's even cancer surgeries we know are down because of having to push off anything that's not life-threatening, mental health, all of those things have been pushed off. So I would be working under the assumption that we're going to have a very serious time of work ahead of us to get caught up.
Now, I would just add that, and I know my colleagues, including Mattapan, have implemented, try to prevent, more crises from happening, such as making sure that immunizations are still caught up for our kids. So pediatric mobile vans. And I know Mattapan has implemented a similar type solution that we've done here in East Boston and the surrounding communities. But then it goes to the food access, housing insecurity, evictions, and things like that, which are all part of a public health crisis, all related to the impacts of COVID in the economy.
Thank you. And my final question, thank you, Councilor Arroyo, but my final question is maybe to Manny. Manny, I know East Boston Health Center is also, partnering or merged with the South End Health Center as well. South End has a high concentration of Asians, as you know. But I guess my question is, the lowest screening for breast cancer for any ethnic group is Asian woman. And I say that because what would your outreach be to the Asian community during this pandemic that, it's challenging at times to make sure that we educate people why it's critical to get needed public health services or various exams. What do you think?
Yeah, I think it's we're planning on bringing the same playbook that we've used here in East Boston, which is this is a community effort, whether it's COVID or breast screening or colonoscopy screenings and other things that we know impact our communities, is to bring all of the community-based organizations together, and we take the responsibility as being the healthcare leader to not only share information, but also to gather information from these agencies in terms of how can we better message, how can we leverage their resources to direct individuals to us. But I think that's worked really well in East Boston. If you look at some of East Boston's trends, it's part of the Healthy Boston report. You know, some of the trends that you would normally see in a community that looks like East Boston, but East Boston from a data perspective looks more like Beacon Hill or Back Bay, which is really impressive. So we want to bring that into the South End. And again, I think leveraging those partnerships, we're not going to do this alone. We're going to have to rely on these partners to help us, but they're going to rely on us to make sure that we give them the right information and we create access to breast screening and mammography. Now, unfortunately, South End doesn't have a mammography, a mammogram system, but we do have one in East Boston. And our hope is that we can create transportation to East Boston to accommodate the need.
Thank you. Thank you to the panelists. And as Rita Nieves said, we're so fortunate that we have tremendous community health centers across the city that played a critical role during this pandemic. So I just want to say thank you to the panelists and your staff for doing excellent work during this pandemic and always as well. No further questions, Councilor Arroyo. Thank you very much.
Thank you, Councilor Flynn. Councilor Mejia.
Yes, thank you. I'll just be brief because I know we don't want to hold you all hostage here. I am just curious in terms from a trauma response space, wondering what, if anything, the community health centers and advocates are doing to ensure that we're thinking about the long-term traumatic impact that COVID is having on our community, and coupled with how that may even prevent people from wanting to go get tested. Have you seen a correlation between just what people are seeing in the news and then being afraid to wanting to go and get tested? If you have any information on that, that would be helpful. I'm also curious to know, what have you learned in the last 9 months of the pandemic? What have been the biggest challenges that you have seen? And what would be the biggest change that you'd like to see moving forward? Like, what can we do differently moving forward? I tend to believe that COVID is here to stay for a little bit longer than we have all anticipated. So we got to brace ourselves for that reality. So I'm just curious if you have any information around what would you like to see us doing moving forward? Questions about how are you working together to educate large groups of people who are all living together? I know I'm particularly thinking about families with multiple generations living in the same household like mine. My mom lives next door. Literally, we all eat together. My daughter's 10, my mom's 71, and we have every age in between this household. So I'm curious in terms of what communication is being offered to intergenerational families. That's a lot.
Kwale, you want to go first?
I went first last time. I'm going to let you go first.
Okay. Let me see. Thank you, Councilor Mejia, for the questions. Related to trauma and testing, I think you are absolutely correct. Our communities pre-COVID were faced with significant trauma, particularly the immigrant community who came here from other countries, and whether it was the path to get here or what they experienced in their home countries, the need for behavioral health and mental health services has been always significant. So we've done quite a bit of work at increasing that capacity. Again, making sure that it's in the right language, the language that they prefer to receive it in, and making sure that we have what's called an open access model. So you've heard, one of the biggest challenges, not only within the city, state, and nationally, is getting access to behavioral health services. So in our open access model, you call us today, you will be seen today. And that's a significant benefit, because folks who are experiencing trauma can't wait for care. We continue to provide that service. You know, there is, if you would, some good news, which is hard to find and when you're going through a pandemic, but the telehealth services have actually worked very well for behavioral health services. You know, folks have complicated lives, work multiple jobs, and sometimes can't find the time to access care, again, when they need it. But by deploying telehealth in our behavioral health services, we are seeing a significant surge, if you would, in behavioral health services being accessed by our patients. And in fact, our behavioral health team has done a phenomenal job at actually going back and looking at individuals who have no-showed for behavioral health care and opened up telehealth services to those individuals, and they've accepted it. So I think that's been great, and we'll look forward to continuing to offer a hybrid in-person or telehealth service post-pandemic. Some of the challenges, you've heard many of them before, and it's supplies. You know, given that our national response was not where we expected it to be, and it was every state, city for themselves. And we're fortunate to be in Boston and be in the state of Massachusetts because I think we have government individuals like yourselves who helped us and responded very quickly to our needs. But I would say that would be the one area where we could have done it differently and making sure that we had the supply that we need and making sure that stockpile was there for an occasion like this.
I would mirror, I'm sorry, Councilman,
no.
Thank you for the question. And I would mirror what Mr. Lopes has said regarding behavioral health services. Before the pandemic, we were experiencing 30% no-show rates. After the pandemic, we switched to a telehealth model and we did it very quickly. Our no-show rate is 0. And for a while, we were able to keep up. Anybody who wanted to be seen, we were able to see them. And now we've gone to a triage model. If it is a serious situation, if it is a serious case, we will get you in. But we're having now to ration the service because of the demand that's in place. What we're seeing is an increase in the complexity of the cases because people are frustrated, people are angry, and that is being manifested within family units. So we're being very cognizant of how our own therapists are reacting to that and trying to take care of that. You asked about what we've learned in the last 9 months, what the challenges we face. You actually used the one word that I would use to answer that, and that is the word change. We are changing on a dime, and we're changing, it almost seems like on a daily basis. This new testing model with the rapid test. We received those tests on a Friday. We completely had to reconfigure how we're administering those tests. And we did the first test literally 2 days later. And every health center across the city and across the state is doing the exact same thing. We are adapting quickly. And now we're having to make adjustments and figure out how we're going to vaccinate. So continuing to do testing, modifying the testing. And go ahead.
Oh, you could see. Oh, I was about, no,
okay.
Finish.
And then,
because I want to make sure that Councilor Arroyo lets me ask one more question. That's all I want to make sure.
You do, you certainly do.
And regarding messaging, we participated in 2 town halls with the Boston Public Health Commission. And one of the things that we've been thinking about to get a vaccination message out in a way that's appropriate, in a language appropriate way, is to do additional town halls. Maybe make them shorter, like half-hour town halls every week, and have a panel of our, a physician, a caseworker, myself, and to do these town halls on a weekly basis to help get our message. So that's one of the things that we're considering. Thank you.
Yeah. Thank you. And I wanted to ask Sam Scarpino a question. I'm curious, you really set the stage in terms of what's happening across this world. And it seems like our people of color are being hardest hit. And knowing that, and because there's so much fear in our community, and because we don't trust government, and because we're the ones who are we're already facing, we're the odds for us to survive anything is stacked against us as it is. What are you hearing in the space that you operate in terms of just helping people understand how important it is for them to consider the vaccination? But also, I know we're going to have a hearing about this later, but I'm just so incredibly, like, when you talked about this, that this is happening across the globe, and that even in other countries, Black and brown and people of color are still the ones who are the highest risk. It just seems to me like we're under attack, right? And if it's, we're damned if we do and we're damned if we don't. And so just kind of like, any words of encouragement or anything that you can say that I can go back out into these streets and help people understand how important it is for them to get vaccinated and why we should trust the government.
Well, I mean, I certainly don't have answers. I wish that I had something that was going to be more helpful. My thoughts would be two on this, based on things that are different now than they have been for some past pandemics. So the same was true in 2009 for H1N1. The same was true for Zika virus in terms of how it hit communities disproportionately. We just didn't see it because the data weren't being collected, oftentimes because access to care and trust and confidence in the government correlates very strongly with whether communities are represented in data sets or not. And one of the ways, and I'm sure everybody is quite familiar with this to larger extents than I am, but one of the ways that governments and communities disempower communities is by not having data on them in the official records so that those communities cannot advocate for themselves. And that is different for COVID. We know that it's law about reporting by race, ethnicity, and things that we know are markers of the effects of racism and xenophobia. And so it's not a bright side, but it is a start that the data are there now that show on the front page of the papers the disproportionate effect, which provides an opportunity to advocate on behalf of the needs of the communities that have been hit hardest. And then, in terms of the vaccine, I think it has to be, the kinds of coordinated campaigns that we're seeing in the Boston area, where you're engaging with the communities in order to build trust and support in the government. And that, again, that this is an opportunity to start that process. But I think, and you understand this far better than I do, and as the city councilor, as all the city councilors do, but that, COVID's a local disease, but public health is almost always a local problem. And that's why I've always been skeptical, as many public health officials and epidemiologists are, about top-down orders and enforcement. It's about education, buy-in, and access. And that we have an opportunity to demonstrate that is the playbook, in the greater Boston area. Because I think we've got a lot to be proud of, a lot of work to do, but a lot to be proud of at how we're trying that model here in many different ways. So I think that's the best that I can offer. And I think that is, to me, it's a big difference for COVID, to be honest with you, that we actually see the statistics being reported and talked about is not something that's happened for previous pandemics, at least that I've worked on.
Thank you. Thank you all for your answers. And thank you so much for all the hard work that you do on behalf of our people. It's greatly and deeply appreciated. Councilor Arroyo, I don't have any further questions, and thank you for your leadership in this space.
Thank you. And Councilor Asari George.
Thank you again, Mr. Chair, and thank you everyone for being here. We certainly appreciate the role that our community health centers play in our communities in delivering healthcare and other services, but also grateful for your continued leadership and in offering sort of advice and presentation and counsel in response to our questions today. You've always been ever present, especially in my work on the city council, so I'm grateful for that. Sam, you brought up in your presentation the spike that we're seeing now in children under 18. I'm wondering if part of the challenge, and perhaps Manny or Gwali can respond to this, are children and young people under 18 not getting tested at the same rate as adults for a variety of reasons, either the public discourse around the low infection rate or fear, or whatever the case might be? And have we now shifted to doing more testing? Are you seeing an increase in testing? And perhaps that's where the spike is coming from. And then the hospitalization piece, are we waiting? Is there any sort of information that may say or show that we're waiting longer before we hospitalize our children, for example? I don't know. And so I think that in the health centers, are you seeing, I've been tested a few times at my community health center at Dot House Health, and there was once a child in line, and that child happened to be with me, but I've never seen a child in line otherwise.
I haven't seen an increase in testing. I'm not sure. I can go back and look at the data but you're right. Particularly at the beginning of this pandemic, there weren't too many testing facilities that were testing young kids. Particularly, I believe, under the age of 5. We were doing testing all ages, and there were many kids that were being sent to us from other facilities to get tested. So I'm not sure in terms of this. I can't speak to the spike in hospitalization. I think when you saw the data from the commission, it did, at least from the trending, I haven't seen any trends that shows a spike in positive cases in young children.
I suppose the spike was really the hospitalizations.
Correct.
And I wonder if that is attributed, or could we assume that's attributed to potentially a delay in accessing care for a child?
It could be. I think one of the things that we also unfortunately don't know from the HHS data is whether these were primary COVID admissions or whether this was a COVID positive test because of an admission for another reason.
Yeah.
So these are individuals who are hospitalized currently for COVID. So it's possible they caught the COVID infection and are treating it as a result of something else. But the fact that it's up over the past few weeks is what's concerning, where it had previously been flat. And so I think that there are a number of possible explanations. We know that the hospitalization protocols have shifted. The time people are spending in hospitals have changed. Everything is kind of shifting over, especially as the age distribution shift. So it could be, it's probably a combination of a number of factors, but I think that's why it's important to understand more about what's going on. And unfortunately, we can't go any deeper in the data that we have.
Right. Yeah, no, curious about that. Oh, go ahead.
Probably, George. I just did a quick check while you were asking your question, and we're not monitoring at that level trends by age group. We're just monitoring it in total and the positivity rate. But our total testing as a percentage of 20 and under is at 10%. All the tests we've done, 10% are 20 years of age and under. And I think at a health center, from a health center perspective, striving that for the parents. I don't think we're going to, if the parents feel that the child needs to get tested, and that's the driver, not if the parents feel that there's an infection, a possible infection, then that's what's going to drive it. I think that's why the percentage is at 10%.
Have you seen that 10% go up, or has that been relatively consistent?
It's been relatively consistent.
Okay. Yeah. So, I mean, certainly that information, then Sam's presentation just creates more questions without answers, but appreciate the presentation and everything else. I am now off to a parent meeting around driver's ed. So I'm sorry that I have to disconnect at this time.
Good luck.
Good luck.
Yeah, good luck.
Thank you.
Thank you.
Councilor Arroyo. Thanks.
Thank you. And so it looks like it's me now. And so I'm going to go right into my questions. Specifically, I think, Mr. Lopes, you said you're running the Hyde Park site?
Yes.
And that eventually we'll get testing up to 500 tests?
Correct. Probably in the next couple of days.
And I know right now, I think officially that testing site is open from this past Tuesday, which is about today, until my days are all a mess. It's all a mess. But today until Saturday. But is the goal to move longer than that, more long-term at that site?
Not right now. Again, if we need additional capacity, that's one way to increase capacity by increasing the hours. We're still challenged by staffing. There is a staffing shortage of nurses and other people to do testing. So that's also one of the challenges that we're faced with. But
in terms of extending the time frame is what I mean more so. So is that site going to be open for a longer amount of time than just those 5 days?
Yes. So with our contract with the city, as Chief Martinez mentioned, right now we follow their lead. They direct us on where we go. And I think right now the commitment is to stay in Hyde Park for 6 weeks, I believe, if not longer.
Perfect.
Sorry for misunderstanding.
Sorry, no, I realized there that you might have misunderstood that I meant the time frame of time, not in a single day. Okay. So that's very good news for me. So thank you very much for your efforts there. One of the questions that I have for both of you, as candidly as you can be, what are ways in which, just looking ahead, we have another budget coming. That's next year, right? You're operating on this year's budget. But what are specific ways that the city can invest or be of service in resources or whatever it may be to our community health centers, because you have been carrying so much of the load in the pandemic, frankly, and I don't expect that to go away just because vaccines are coming in the next couple months. By the time we're talking about this budget again in June or July, I expect that you're still going to be seeing an increase in use of services. And more candidly, I think we're going to see an increase in the services like mental health and trauma that we haven't necessarily reckoned with yet. And so in what ways can the city offer additional resources to you either now or in the future that you are foreseeing as things that we should look at?
Yeah, I guess I'll go first again and just say that, number one, I think, again, we're very fortunate to be in this city that has provided significant resources, whether it's through the Resilient Grant or the CARES Grant that the city received, and sharing that with the health centers within the city. We're also, fortunate to have a lot of health centers, 20 plus health centers in this city. And naturally, in a pandemic like this, we see the value of having health centers right in the neighborhood, people who work at the health center come from the neighborhoods we serve also. So thank you for acknowledging and recognizing the value that has always been there. I would say going forward, making sure that health centers are financially viable. And I know there's going to be, and appropriately so, a lot of asks on the table. There's a lot of small businesses as well as large businesses who have been impacted by this virus. And I would just make sure that health centers are also on that list because pre-COVID and going into COVID, our operating margins have usually been in the negative 1%. And that's not sustainable long term. So to the extent that the city could find ways to bring additional resources to shore up our community health centers for times like this, or even when there isn't a pandemic, to making sure we continue to provide the services and need for the residents of Boston, I think will be extremely important.
I strongly agree with how fortunate we feel with the support that we.
Mr. Valdez, your speaker goes in and out.
Okay, clearly, let me move this a little bit closer. Let me try this again. I agree with Mr. Lopes, strongly agree with Mr. Lopes. We've been very fortunate to be the recipients of the financial support up until this point. And I've had conversations with Rita Nieves on a Saturday to say, can we redirect some of the resiliency funds to cover staffing, which was not at times the original intent. And the response was absolutely. When this pandemic is, even now, but especially when this pandemic is over, the need for our services is going to be greater. And we're going to have to fund positions that do not generate revenue. I can use outreach workers now, and I don't have a way to pay for them. Outreach workers to coordinate care, outreach workers to coordinate behavioral health care, primary care services. And once again, traditionally, we need to, it would be helpful to be able to fund these positions and to have the flexibility to use these positions to provide that care. It's easy to hire, it's not easy to hire a doctor because it's very hard to find them, but a lot of our positions generate revenue and we get federal grants. But some of our positions, registration, we're going to need it at all levels. And our staff are tired, and we're going to need to supplement. We need to supplement our staff. Registration position does not generate revenue. An outreach worker does not generate revenue. This is where it would be helpful, is to be able to fund and we have to be practical. We know there's going to be a lot of constraints on the city budget, but every one of us could use help in this area to be able to fund these positions to help us continue. I want us to grow. I want us to grow, and we have the potential to grow. And we're going to need the infrastructure to be able to do that. And I think providing, if I have to give you if I have to give one recommendation, it would be for staff. We can use the additional staff.
That's all very helpful, actually, and I appreciate your candor on that. And I will tell you that I know it's going to be a tough budget, but I think if we're not investing in the health of our city, we're really not investing in what I consider one of the key priorities for any city. And so this is going to be something I'll be in contact with both of you, frankly, offline, just about these kinds of conversations, because, I know for me personally, one of my major concerns is there's a lot of trauma in our neighborhoods that existed prior to COVID. And I think when we talk about PTSD and all the different ways in which we see sort of crime or outbursts or different things that are happening in our communities, and how that relates to mental health and mental trauma and the lack of resources to address that, add several thousand deaths, add months and months of isolation, add job loss, income instability, housing instability, the loss of your business. And we're going to see a lot of need for mental health that we haven't even come close to appropriating funding for or resources to. And so this is a major focus for me, and trying to figure out how we do that. And I'm going to speak with you both online candidly just about ways in which we can try to figure out, how your budgets work better than me, ways in where the dollar we give you goes further if it goes here or there. But those are the kinds of questions that I would love to have answered later. And I'll spare you that now just for sake of time. In terms of where we are with rollbacks and safety rollbacks and things like that. And I think one of the issues for folks making these decisions, frankly, is that they're trying to balance something that there's a split in the populace. If you make a move now, it's too drastic. If you make a move now, it's not far enough. And there's a constant balance with public perception as to what is appropriate and what's not appropriate for businesses that are open or not open. Neither of my community health centers have any say in that. And so this is really for Mr. Scarpino. Personally, I think we could go further with what we've rolled back. And I think we should have, frankly, gone further with what we've rolled back. As an epidemiologist, as you look at these numbers, as you sort of have seen this and framed this, and this isn't your first time in front of the council, very early in this outbreak, we've had conversations about sort of what waves would look like. What would you recommend regarding reduction of transmission in the city specifically, but also just what are policies that we should have already done, or we should be circling on the schedule of things that might have to be happening soon?
It's a great set of questions, Councilor Arroyo, and I would say I think there are no easy answers, which I realize is, I think it's the third time I've used that answer today. One of the big challenges, and we see this clearly in the data, is that if the bars and restaurants or gyms are open in the neighboring community, people will often go to that community to use those services. And that has created super spreader events in the past, and it has led to regional transmission of COVID where you move between communities. And in some ways, it can be a worst case scenario. So I would say that it's important that we saw coordination outside of just the city of Boston around these measures. And the more coordination we can build, the better the effect is going to be. And one of the other pieces of this that we've seen is that early action, even if it's not perfect, is better than waiting and trying to do it exactly right or to put in harsher measures a little bit later. And so I think it is important that we did something that was a little bit more serious than what we saw coming from the state, and that we built a little bit of a coalition around Boston to kind of buffer more with respect to what's open and what's not. I think from my perspective, the biggest challenge is that we don't know where most of the cases are coming from, right? We hear from the state 50% ascertainment. I would guess that of that other 50%, we're not that sure of probably half of those, right? And we know that about 51% on average of cases come from people that are pre-symptomatic or asymptomatic, which means it's going to be hard to figure out where these cases come from. It's not often because of a lack of, I mean, a lot of it is because people don't answer the phones, as we heard. It's a challenge to get in touch with people. We need more contact tracers, et cetera. But it's also, even if you get a hold of people, hard to figure out. And that, makes it difficult to come up with a kind of targeted intervention. So why am I leading into this? Well, the one piece of data we consistently see is that dining is high risk. And it makes sense because we know that masks are highly effective, and dining involves taking your mask off for a period of time. I don't really know what options we have without a bailout from the government, the federal government, or from the state. And I think, actually, to be honest, one of the concerns that I have is in the data, people do what they're going to do. And what do I mean by that? Like, if they're scared, they're not going to go out to eat. They're going to shelter in place. We saw that in the spring, that restaurant activity dropped well before any of the mandates went in place. As people working in public health, again, we understand that it's about education, access, and buy-in much more than top-down enforcement. And so one of the concerns is that we don't have more measures in place that come with the necessary financial and economic support for those sectors, but people are going to avoid those settings anyways. And so the revenue is going to go down. And so those sectors take a financial hit. We don't get the benefit necessarily from COVID transmission reduction. And because the bars and restaurants or other venues, in quotes, don't get closed, they don't come with the necessary financial and economic support. So I think from my perspective, it's important that we're doing something. I agree that we need to do more. It is not clear what the good options are that are still left on the table, given the lack of statewide, and honestly, the state might not even have the budget to provide the kinds of support that we would need, especially if the restaurant, bar, other sectors are involved. The other piece that I would add, one of the things that we're not great at in this country, among many, when it comes to public health, is tracking vaccine uptake. And as we roll out the vaccine, the landscape of COVID across the city, across the state, across the nation is going to get even more heterogeneous and patchy than it is now. And that's going to make it very difficult to track flare-ups and hotspots and deploy resources and alert the community health centers, and all the things we're doing now are going to get harder as COVID starts to get increasingly rare, because right now we can just kind of assume it's ubiquitous. Almost everybody that's walking through the door with respiratory illness, there was an RSV outbreak a couple of months ago, but it's mostly COVID. So it's a lot, quote, easier than it's going to be from a surveillance and data perspective. We're also going to have to be monitoring to look for the effect of the vaccine at interrupting transmission. It's one of the things that didn't come out of the trials. There's some suggestive data in the Moderna filing through the FDA, but we're going to have to be tracking that from an epidemiological perspective. And so making sure that we're getting data on vaccine uptake, in addition, not only for the equity piece, which is going to be key, that we can demonstrate the vaccines are actually going to who we all think and have prioritized for them to have access to, and that it matches the equity requirements, but from the epidemiological perspective, that we understand where the vaccines are going so that we can measure the effects and provide the appropriate kind of situational awareness to the health facilities. So I would say those are the two biggest pieces, is that to the extent we can continue to build coalition, outside of Boston, even if it's just around the current measures, that's a big deal. I think we have to figure out how to roll back more in person, as we heard from Chief Martinez. Anything non-essential is the things that we need to be targeting first. And, you know, until we can get a bailout from the federal government, I think we should all probably assume that dining is going to be the last thing on the table. And so being as creative and thoughtful and compassionate as we can around the other non-essential indoor gatherings. And then the second piece is around tracking the vaccine uptake as we move forward. And of course, we're fortunate in Boston, but the critical aspect of the messaging around that is as the rollouts happened.
Thank you for that. That's actually very comprehensive as an answer, so I appreciate that. And I would be nowhere if my staff wasn't writing down all of your answers as they come out, so that I could go back and dig into them. In terms of 2 more questions for my community hospital partners, and then 1 more question for you, Sam, and then I think we're concluded here. Once we get past our, we have 2 folks waiting to do public comment, and so I'll go to them directly after that. My first one is with vaccine costs. One of the concerns that I have with this is, my understanding is that Mass Health may not cover these. And if these aren't covered by Mass Health, that's going to serve as another barrier for equitable distribution of vaccines. Do either of you know whether or not Mass Health has been on board or has confirmed in any way, shape, or form that they will cover vaccines?
I have not.
I have not heard. My understanding is the vaccines have been paid for by the federal government and that they are free. So the coverage of Mass Health may be for administering the vaccine, but you know, today our assumption is that the vaccine will be available and administered at no cost to everyone.
My concern is that we heard the same thing on testing, and then it became, okay, well, if you have symptoms, your test is free. But if you don't have symptoms, that's going to be an insurance hit. And my concern is we might see a similar switch or clarification as vaccines get rolled out. And so one of my questions is, how have the community health centers treated folks who have no coverage for testing? Because I think one of the questions I have is whether or not this is something where we need to create a city fund in advance, something that we're prepared to dip into for folks who need that for vaccinations, or whether or not this is something we can do a private-public partnership with. But what have you experienced with folks who have had issues getting their testing covered by insurance?
What we do is we take down demographics, we gather your insurance information. And what we tell you is we're going to bill your insurance. You will not get a bill. And we have an arrangement with Quest. Quest is our testing partner. And they're in our building. Quest is not allowed to bill anyone for a test. That cost once a month comes back to the health center. And we're still very fortunate to have some grant funding to be able to do that. At some point, that grant funding is going to dry up. And at that point, then we would reach out again to our federal partners, our state partners, our city partners to see.
Do you know how much, do you know, even if it's a guesstimate, do you know how much money, say weekly or on average, that you're having to chip into that? Is it a large amount of folks?
And Quest just lowered the price to $69 from, I believe it was $169. It's a couple of $1,000s a month. We're still finding that insurance.
Is that specifically for Mattapan Health Center, or is that for all
specifically for Mattapan? It's
Okay,
specifically
so
for Mattapan.
Could be thousands on months for every.
Correct.
Okay.
I think what's different, I would agree with you, Chairman, that in testing, there wasn't a consistent and, again, national or federal strategy around testing that made it available to all, you know, and we didn't have to collect insurance information or try to figure out who needs to pay for those testing. I think with vaccines, at least we're seeing a different approach where it is at the federal level. The federal government, my understanding, has picked up the cost of those vaccines, and hopefully they'll continue to do that, and that it will be delivered for free. Where testing, unfortunately, we did not have the same type of national strategy and resources, and it was left up to states and cities, and partly the CARE Fund, the CARE Act helped offset. So some of the grants that we're getting are from the CARE stimulus package. But again, it became really confusing because we were required to build first and identify and collect information first before we can access those grants. And that did cause quite a bit of confusion within the community because people were asking, why do you need to collect this information? Why are you billing my insurance company? But we were required to do so before we can access the grants.
Yeah, and I'm grateful to both of you and frankly our community health centers for finding a way to not pass that on to the testees. That's deeply appreciated. My last question, and I'm going to have to dig into the vaccine cost one privately with the administration and with you, because I am concerned. Until there's a real idea of how much that money is going to be, I'm concerned when they start sort of say blanketly, yeah, sure, of course we're going to cover this, because usually there's some kind of clarification that comes once they realize what that check looks like. And so I'm hopeful with the new administration, but I want to make sure that we're prepared in case that's the situation we have to confront. In terms of college partnerships, when we're talking about staffing levels for testing centers, for ways in which a college partnership could work out, are there any college partnerships that are currently being explored for testing or for staffing, or ways in which we're sort of using them to raise up these gaps? Are they participating in that? Is that a resource that we're able to use?
We haven't used any of those resources from the colleges.
Is there any reason on your end why you would not be amicable to that? Is there a reason why you wouldn't want those partnerships? Or is this just something that is worth exploring but isn't being explored right this second?
I think it's probably worth exploring, but I think the colleges have their own challenges on campus and off campus. The irony in all this, they've asked us if we could help them. And in fact, we offered help to our partners at Bunker Hill Community College because they are our partners. So we were doing testing for them for a little bit of time before they ramped up. So I think, look forward to any partnerships, as Mr. Valdez mentioned, our community health centers, our hospital partners, and others, because this is when it's a team effort to get to the work.
I appreciate that. And I think that's my final question for y'all. I do have one for Mr. Scarpino, which if either Mr. Lopes or Mr. Valdez wants to jump in on. I will say that one of my concerns with the numbers that I've seen from the state about where things are being transmitted, when they get into the nitty gritty of it, they have a number of transmissions within household, right? I think it was like 20-something thousand plus transmissions traced to a household. But for me, what that actually traces is that their contact tracing is likely not as robust as it needs to be to actually pinpoint where exactly this spread is occurring. And so, Mr. Scarpino, as somebody who looks at numbers and sort of understands both the data that you're looking at, but also data collection and how data collection matters, what are we seeing specifically in terms of our contact tracing? Where can that be shored up to ensure, and just to clarify why I care about this, when the state or the city says we're following the data informs our decisions, we're only as good as that data. And if what that data is showing is, for instance, household transmissions, without tracing it back to where that household transmission originated from, then we're never getting into the nitty gritty of how the spread is happening, where and what is actually formulating or forcing that spread. And a lot of that requires robust contact tracing and the ability for me to say, Mr. Scarpino, clearly, for instance, in an example, you passed this on to, Mr. Arroyo at his home. Where did you get it is a very important question. And if we just relieve that as a household transmission, rather than Mr. Scarpino was on a bus, Mr. Scarpino was at the gym, Mr. Scarpino was at a restaurant. Being able to trace where these exposures may have happened, my concern is we're not doing that much beyond that first layer. And is that something that you've seen with the data? Is that something you're concerned about?
It's something that I'm very concerned about. So, from the perspective of COVID, once it's in the household, it's very hard to control, right? Unless you have the ability to move individuals into safe isolation or quarantine housing, or if people are fortunate to have housing situations where they can isolate. So I think the real question is, how did it get into the household? And that means we need to understand where the transmission events are happening out in the community. So when I hear that we can't identify the source for 50% of the cases, we're already failing. But then when I hear that of the remaining 50%, close to 50% or more of those are household transmission, well, that's about what we'd expect, that 25 or 30% of all the cases are coming from household transmission, but that doesn't tell us what we can do to actually intervene, right? What we need to do to intervene, as you said, Councilor, is understand how it got into the household, because that tells us what we need to do to actually slow down the transmission. It's the thing that we see work very well in many other countries, in other settings, often what's referred to as case investigation as opposed to contact tracing, where you're trying to understand where the cases came from, right? And we've seen this on the front page of all the world newspapers, article in Science coming out of Harvard University, a big international team, estimating that hundreds of thousands of cases all trace back to that Biogen event back in February, right? And so the question really is, how is it getting into the household? And so until we're seeing 60, 70, 80% ascertainment of where all the cases are coming from, and we're understanding in a very granular fashion where individuals are getting infected that then bring it into the household, we're going to have a lot of trouble responding. It's a big part of the reason we're in this current situation, both because that's how you control COVID, is through test, trace, isolate until we have the vaccine. So one, it's a direct feedback on COVID, but two, it pretty much leaves us with only bad options for how to respond, right? Which is basically do nothing or shut everything down, because we don't have that understanding of where actually the cases are coming from so that we can try to maximally intervene. So I guess just to restate, I agree that follow the data is great, except when we know the data are not telling us enough about what's happening. And I would say with the contact tracing data, there's overwhelming evidence that we don't know enough about where the cases are coming from to really intervene. And that's a big part of the reason that we're in this situation now, being faced with trying to decide what to do as we're entering into this surge without really knowing where the cases are coming from.
And Mr. Scarpino, just a question, a follow-up on this, and then we'll end it here. This is clearly a world issue. Are there any best practices that we can maybe impart on the city or on the state for case investigation, which I think is a good word for that, because it goes beyond contact tracing and tries to really identify where spread is happening? Because what I will tell you is I consider this the issue, really, with our response problems. Part of the issue that we have is, our response now isn't much different than our response when this first broke out, which is we don't have a clear understanding of what's driving the spread. And the only reasonable answer in that case is to shut down everything so that you kind of catch it in that net. But other countries have found a way to isolate. We do know where and what is driving some of this spread, and we've been able to sort of identify and shut those things down. And I think we need to get to that. And so the question that I have for you is there any best practices from other countries or even in this country where they've done a better job at identifying or finding a way to identify what's driving and causing spread beyond just, say, a home, right? Like, is there any way that we can sort of create best practices or advocate for best practices on this?
I think that the two short answers. So the first is, when the case counts are this high, no, because part of the problem is there's just so much uncertainty on where somebody could have gotten infected that it's very unlikely that you're going to gain that kind of certainty. The thing I keep coming back to as an example is that super spreading event in Maine at the Big Moose Lodge, where you had a few days later people getting infected 200 miles away down in Portland because individuals had gone from the wedding back to their homes in Portland. And Maine only knew that because they had a handful of cases at the time and an army of case investigators that were able to trace all of those paths. But once you get a lot of cases like we're in right now, what you see in Australia is they shut everything down until the case numbers get low enough. And then they cluster bust is what they refer to as in Japan, where you deploy armies of contact tracers to clusters, you trace out and you get everybody quarantined and isolated, and you try and shut down the transmission that way. So what does that mean? Well, I think to me, what that means is one of the things that we could and should have done differently in the summer is really to go for eradication locally of COVID through this kind of test, trace, isolate strategy once it got really rare. And we didn't do that. We're going to have another chance with the vaccine as we start to bring those low levels of infection down with the vaccine as we exit out of this surge. We're going to get another opportunity to do this. And we need to learn from our mistakes in the past and have this robust case investigation system. And as we heard from the community health system, we're benefiting from the fact that we have a lot of community health centers, that part of the problem with case investigation and contact tracing is trust and access and interaction with the community. And we've got an advantage there in Boston over many other places. And so I think that's the kind of thing that we have to be ready to deploy, especially as we go into the vaccine era. Now, very briefly, there was a paper that just came out analyzing lots and lots of non-pharmaceutical intervention responses from many different countries. And the consistent things that came out were dining and group sizes. And you've got to keep the group sizes down, 10 individuals or fewer, and you can't have indoor dining open. And unfortunately, indoor dining has been something we can't touch without a federal bailout. So our hands have almost been tied there. But otherwise, I mean, mask wearing, of course, is critical. You got to assume you have the mask wearing, and we've got that. We're very fortunate about that. It's been one of the big success stories in the Boston area and Massachusetts is mask wearing. But so mask wearing, but then it's group sizes less than 10, which also makes the case investigation easier into contact tracing, and then it's dining, and everything after that seems not to matter very much. That it's those things that are critical. So I don't know if that's helpful, but those would be
that is helpful.
Those would be what I can offer.
That is helpful, and I appreciate all of you for taking this time. Unless you have anything that you'd like to close with, you're free to go. I'm going to go to our community comment, but I want to thank you all for being here. And if you do have anything to add, you can just chime right in on your way out, or if you just want to head out and enjoy the rest of whatever day you have left, you feel free to do so. Thank you, all of you, for being here, and thank you all for the work you're doing. I deeply, deeply mean that. Thank you so much.
And thank you, Chairman.
Yeah, thanks for having us. Thank you very much for having us, Councilor Rono.
Thank you. Now we'll go to the community comment portion. Mr. Whedon will be first. Just name affiliation if you're speaking on behalf of a organization or program or community organization. Neighborhood, if not, and then 2 to 3 minutes. Mr. Whedon, the floor is yours.
Great, thank you very much. I hope you guys can hear me okay.
Yes, you're there.
Great. Yeah, I live in the Kenmore area, and I'm actually on the faculty at Boston University, but I am not speaking for the school. And I want to say at the outset, I very much appreciate all the things that you guys are doing. And this last 2.5 hours has been a great education for me. What I was going to ask you to do, and I don't think it has come up in the time that you guys have been talking over the last couple of hours, is that there ought to be a focus on one big hole in preventing community spread, and that's the lack of COVID compliance at Boston construction sites. As someone who lives near 2 of those large projects, both the big Kenmore Square project by Related Beal and the Boston University Computer Science Building, a 17 or 19-story building that is going up a couple of blocks away, it's impossible for me to walk through the community and sometimes even to go to the trash can without encountering the workers on these sites. And although it's counterintuitive that you wouldn't see high compliance at these sites, because you would expect that the workers would understand that they were shut down for a long time in the spring and summer, and because most of them only get paid when they're actually able to be on the job, there appears to be a cultural or attitudinal gap that is preventing an adequate level of compliance at and around those sites. I find this especially dangerous in the context of the things that you guys have been discussing, because this is not just a matter of spreading within the single community in which the interactions occur, but these are all people who interact with each other. They come from various places in the greater Boston area over the course, when they come to work in the morning, and then they disperse to various communities within the Boston area and the city of Boston when they're done. And so whatever happens and what on the job site is something that they take with them home every day to those communities, and anything that happens at home is something that they bring to the job site. The current approach is clearly not working. I've attempted to reach out to the Inspections and Permits Department starting last week. Very slow to respond, very slow to take any significant action. I finally got a call back yesterday morning, and I believe the only action that has been taken since then is that the person from the department called the project managers on the two projects, but didn't actually visit the projects to check compliance herself, and reminded them of their obligation to comply. And that is simply not working. I will tell you, she sent me that email yesterday. I walked by both projects today. I've got both photographs and my own observations showing that compliance was still not happening today. I've also reached out in the case of the BU project to the owner, one of the senior VPs at BU. And in the course of interacting with those folks, what I realize is that the owners of all of these projects really don't have a very strong incentive to maintain compliance. They're behind on the projects as it is because of the difficulty in getting workers, because of the shutdown period. They certainly don't want to disrupt those projects. They have financial and other incentives, and the contractor certainly has financial incentives to finish on time. And so compliance is certainly not the highest goal there. The comments that I've gotten from people on the BU end, for example, are that they share my exasperation that this is a daily problem and the consistency has been an issue, but yet the projects still remain open at full capacity with people coming to work and people congregating around the site and traveling to and from the site, from the T station in Kenmore, from other places without wearing masks while they are encountering other people from the community on the street. Literally every time I have been by one of those sites, there's been both a lack of social distancing and a lack of appropriate protective compliance. As you heard a minute ago, masks are probably the most important thing that we can be doing. So I just wanted to make sure you understand that although it might require some disruption in construction schedules, that there may be further action that needs to be taken. And I'm hoping that you guys are more successful than I am in communicating the importance of the Inspections and Permits Department in enforcing the restrictions that every one of these contractors has already agreed to, but isn't really enforcing in reality out there on their job sites. Thank you for your time.
Thank you. And that's something that we'll look into for sure. It did not come up during this hearing. You're correct, construction sites, but I know it's something that we've brought up in the past, and we'll certainly look into those concerns because I take those seriously. So thank you so much.
I'm being asked to unmute again, but I'm not sure why, but thank you for giving me the time.
No problem. Thank you. Ms. Radwin, the floor is yours. We're asking you to unmute if you can.
Very good. Thank you, Councilor Arroyo. Do you know if the panel members are still in the room?
I do. Right now, it's me, and we have, it looks like one of our community hospital centers still here.
Yeah, well, let me give out roses. First, Councilor Arroyo, thank you so much for a terrific hearing. I learned a lot and heard some answers that I really wanted to hear. I want to give some roses to community health centers. They are near to my heart. I've been a nurse for 44 years, And I'm a principal investigator, and I study trust and healthcare. And the vignette that was given was a perfect example about setting up a trust relationship during testing. So thank you so very much for what you do. Okay, so I just want to respond pretty quickly to Chief Martinez's remarks about colleges. So a paper came out where scientists found genetic evidence of COVID spread from colleges. They briefly put, they isolated DNA from students, and they isolated DNA from patients in nursing homes, COVID DNA. And there was a link. So there's no denying there's community spread. It adds to the other studies that I put into the record. And in addition, once again, the report from the New York Times on December 11th said that 3 Boston campuses were accountable for close to 1/3 of the total college COVID cases in the Commonwealth, that being BU, BC, and Northeastern. And again, these colleges are within 3 miles, 6-mile radius of one another. And they all have full calendars to conduct basketball, the New York Times to play basketball and have a season. The New York Times recently published an article about secrecy about athletics in colleges. They're not being fully disclosing the spread that they have from traveling. And that means that they should be measuring not just the players, but the staff, the traveling crew, the food handlers, everybody. It's not benign. And in particular, the higher education institutes themselves have published articles about the dangers of basketball. It is the worst possible sport to be playing in terms of spread. So, and all 3, as I said, all 3 colleges have seasons coming up. They may be playing even now. So I just wanted to put this in the public record. Again, amazing hearing. And I especially listened to Dr. Scarpino because he teaches me everything, and I appreciate his input. So thank you.
Thank you so much. And I will just say one other article that we didn't go over, but that sort of tracks with what the article you just brought up mentions, is that the New York Times did an article saying that they've traced higher death rates in towns with colleges that have opened, whether those are small towns or big cities. They've seen increases. I think it's a 50% compared to cities and towns that don't have them. So it's certainly something that I think it is the case. I do think we're seeing community transmission, and part of why I value Mr. Scarpino, and part of what I wanted to get out of that last part there with what case investigation is a good name for it. When you don't know what the spread is, you can't say definitively that something is not causing the spread. And that's the issue. And so, you know, it's easy to say colleges aren't contributing to the spread when you don't do the data or have the ability to track it. Just like it's easy to say BPS isn't doing it, or something, or public transportation, or whatever it is, or restaurants. If you're not doing the data to actually track what is causing the spread, then you can do the opposite and then try to allege that none of those things is contributing to the spread. And I think
just to say to your point exactly, it's such easy data to obtain. What you need to do is correlate by the week the college cases that are being reported by the colleges and the community that those colleges are embedded in. It's not.
I think that's a smart way to do it.
Okay, thanks so much. I really appreciate the hearing.
I appreciate you. Thank you very much. And with that, that concludes this hearing. Thank you, everybody. Thank you, Central staff. I know it's been a long day for you, so thank you. This meeting is adjourned.